The use of K-wires for fixation of metacarpal and phalangeal fractures is a well-established technique. These are inexpensive, readily available, and can be inserted percutaneously. The wires can also be removed in an outpatient setting. However, the wires may lose, back out, or break, leading to a loss of reduction and eventually to malunion or non-union. K-wires has low resistance to bending loads, that's why it has to be supplemented by immobilization. This prevents early motion of the affected and adjacent digits, which might eventually lead to joint stiffness, prolonged rehabilitation, and return to function. So the question is, if the fixation construct will be modified, making it into a triangle shape by interlocking them, is this stable to permit early mobilization and will have good outcomes? Good day. Presenting to you my research study entitled Osteosynthesis of Metacarpal and Phalangeal Fractures using Interlock K-wire Technique, followed by early mobilization. And here are my objectives. Can the patients have good outcomes if we interlock the wires and allow early mobilization? As to my specific objectives, we will observe for the following. Loss of fixation as evidenced by wire loosening, breakage, or backing out prior to removal. Fracture union as evidenced by absence of pain and motion on the fracture site, with or without callus formation on radiographs. Malunion as evidenced by a deformity on the fracture site, with unacceptable angulations on radiographs. Non-union as evidenced by presence of pain and motion at the fracture site, without callus formation on radiographs. And lastly, pain during range of motion of the digits, as graded using the visual analog scale. This is a descriptive study design with a minimum recommended sample size of 12. Purposive sampling was used within 1 year of data collection. Here are my inclusion and exclusion criteria. Eligibility was determined by the primary investigator together with 2 orthopedic residents. An informed consent was signed prior to the procedure. The intervention was performed by the same team who assessed the eligibility. Closed fractures were treated immediately with the technique, while those with open fractures underwent single-stage debridement followed by immediate fixation. Reduction and fixation was done using 2 K-wires. The exposed ends were bent and crimped to each other. A passive ROM was done to confirm stability, ensuring there is no impediment to early mobilization. Thin dressing and neutral roller splint was applied. After 48 hours, the splint was removed and all patients were referred to PT rehab for range of motion exercises. Should there be any loss of fixation during the range of motion exercises, revision will be done as needed. The outcomes were evaluated still by the same team. There were 2 follow-up periods. The data gathered were analyzed using EpiInfo software, frequency count, and percentage. A total of 22 fractures were fixed and evaluated. All are males with a mean age of 35.8 years, majority composed of open fractures. When it comes to hand dominance, 91% were right-handed and 68% of the fractures involved the left hand. In 77% of our population, the injuries occurred on their non-dominant hand. The common mechanisms of injury were vehicular accident and an occupation-related crushing injury. The proximal phalanx was the most commonly fractured bone. Loss of fixation was noted in only 5%, same as true with the non-union. They were noted to be open fractures that occurred in the small finger and its metacarpal. No fractures went into malunion. We observed pain during range of motion in 18%. These were noted to be intra-articular fractures involving the thumb and small finger. No pain was reported on the joints of the non-affected digits. Fixation of hand fractures using K-wires is a common technique. Its advantages, availability, and cost-effectiveness makes it a common fixation device in our setting. The gender, mean age, most commonly fractured bone, and mechanism of injury reported by the following authors were almost similar to our findings. However, the involvement of left hand and an open fracture type observed in our study were in contrary to the reviewed literature. The technique we performed was identical to the one did by Farias and colleagues, and in their study, they achieved fracture union in 96.4% of their population, almost similar to our study with 95% fracture union rate in 22 cases. The following authors reported the following complications of K-wire fixation, with the most common highlighted in red. In our study where we noted 1 loss of fixation, we attributed it to the following factors: open fracture, motion of the small finger when performing ROM, multiple K-wire insertion attempts, and protruded interlock wires hooking during change of clothes. The fracture eventually led to union. As for the 1 case of non-union, the patient was offered bone grafting and possible arthrodesis, but this patient refused further treatment. We did not attribute the non-union to the performance of the technique, but rather to its open fracture time. We did not observe any joint stiffness since we were able to permit early mobilization. The pain noted during ROM can be relieved by oral analgesics. We did not attribute the pain to the fixation technique, but rather to the intra-articular nature of the fracture. The challenges that we encountered was that adjacent structures had to be considered before interlocking the wires. Careful bending must be observed in order to prevent loss of reduction and fixation. Removal of the wires were difficult since we have to loosen the crimped wire ends. The small number of population and short follow-up was due to the COVID-19 pandemic. In conclusion, the technique provided a stable fixation to permit early mobilization of the affected and adjacent digits and had good outcomes. The technique was applied mostly to single fractures with simple configuration. We recommend a larger sample size, longer periods of follow-up, and a comparator group for future research studies. Here are my references. Thank you.
Good day. Allow me to present my study on the initial impact of COVID-19 on the orthopedic trauma surgeries in one of the government tertiary hospitals in the Philippines. By mid-March of 2020, COVID-19 was considered a global pandemic, forcing the orthopedic surgical specialty to adapt quickly. Orthopedic surgeons were faced with challenges in providing continuity of care to patients while ensuring safety. This is a pioneer study on the initial impact of COVID-19 on the orthopedic service of a specific government tertiary hospital. This institution, the only COVID-19 referral hospital in its region, is the main tertiary referral hospital serving a total population of about 4.7 million. We consider March 2020 to May 2020 as the initial impact period since it is around the time that cases of COVID-19 were confirmed in the region. This study aimed to determine the initial impact of COVID-19 on the orthopedic trauma surgeries in one of the government tertiary hospitals in the Philippines. The following are the specific objectives. The study employs a descriptive design with review of records as the data collection method. All charts of orthopedic trauma surgical cases from March 2019 to May 2019 and from March 2020 to May 2020 were gathered and analyzed. The following are the inclusion and exclusion criteria. Descriptive statistics is used to present data in proportion and percentages. For the results, a total of 251 charts were tallied and analyzed. During the pre-pandemic period, a total of 179 patients underwent surgery. 196 surgical procedures were performed. 86% were males. Majority of patients were 18 to 64 years old at 69.3%. 59.2% of the patients were emergency cases. Majority of the surgical procedures were for the lower extremities at 65.3%. During the initial pandemic period, there were a total of 72 patients. 91 surgical procedures were performed. 84.7% were males. Majority of the patients were 18 to 64 years old at 65.3%. No elective cases were recorded for April and May 2020. Majority of the surgical procedures were for the lower extremities at 53.8%. The number of surgical patients decreased in the pandemic period by 59.8%, males by 60.4%, while females by 56%. Similarly, in a trauma center in London, male patients decreased by 20.4%, while female patients by 41.5%. Geriatric patients decreased by 76.5%, 18 to 64 years old by 62.1%, and pediatric patients by 44.7%. In a Hong Kong cohort study, there was a noted greater decrease of 56.9% among pediatric group compared to 35.4% for geriatric patients. In the region, vehicular crashes, sports, and work-related injuries decreased, contributing to the reduction in adult trauma cases. The geriatric group continued to suffer from low-energy falls at home despite the social isolation, explaining similar findings in other countries. Decreased pediatric cases could be attributed to the closure of playgrounds, schools, malls, and other non-essential establishments, thereby restricting their movement. Acute trauma surgical procedures decreased by 53.6%. Postponement of the elective surgeries contributed mainly to the drop. Overall, emergency cases dropped by 51.9%. In a referral center in Italy, surgical procedures declined by 30%, while in Hong Kong, surgical cases decreased by 44.2%. Upper extremity procedures decreased by 36.5% and lower extremities by 61.7%. Similarly, in the London Trauma Center, upper extremity procedures dropped by 42.9% and lower extremities by 60%. However, in a Hong Kong multi-center study, the number of treated upper extremities decreased only by 23% and lower extremities by 20%, since some of their elective procedures were continued. Patient factors that further contributed to a decreased census may be due to mobility restrictions, preference for a private or non-COVID admitting hospital, restricted travel and curfew with work-from-home arrangements, and modified clinical orthopedic guidelines. Promoting conservative management may have also contributed. COVID-19 modification of institutional protocols and government health restrictions has had a great impact on the orthopedic trauma care and practice in one of the government tertiary hospitals in the Philippines. The number of acute trauma surgical patients decreased in the pandemic period by 59.8%, with consistent decrease in all age groups. Total number of acute trauma surgical procedures decreased by 53.6%. Canceling postponement of elective cases contributed significantly to the drop of surgical cases similar to other institutions around the world. The following are my references. Thank you.
Low-cost surveillance for lower extremity fracture union after intramedullary nailing, an experience on 80 signed patients by a Philippine trauma center. Considering out-of-pocket payments as the primary source of health financing in low and middle-income countries like the Philippines, the cost of an implant is one significant obstacle to fracture care delivery. As such, lower extremity injuries contribute to the cycle of poverty, and the economic burden becomes unbearable when the total expenditure incurred by patients is higher than the minimum wage. A nonprofit organization, the Sign Fracture Care International, has developed an intramedullary prosthesis called the Sign Nail. The Sign Nails have shown good outcomes in clinical series and are donated to affiliated hospitals in developing countries, where orthopedic surgeons can thus treat long bone fractures without much concern for implant-related costs. Surveillance for radiographic union must be an essential component of fracture care in low-resource settings, for the non-union entails high complexity of management, making it extremely costly to treat. The radiographic union scale and tibial fracture score, developed by Whelan et al., aim to increase the precision and accuracy of radiographic assessment by individual examination of each cortex in two orthogonal views. The RUS score is a simple, applicable system that can guide surgeons in decision-making in deeming a fracture united, as it provides quantification of the consolidation of the fracture based on the fracture line and callus formation. However, dependence of surveillance on serial radiographs must entail expenses, which may discourage follow-up among patients coming from poor communities. The squat and smile test has been developed by Sign to monitor fracture union. The deep bend shows a restored range of motion. The squat position stresses the fracture site, testing the bone fragments have healed in the correct position, and the smile shows that the patients are pain-free. Subsequent validations of the proxy only emphasize the need to come up with low-cost strategies for assessing fracture union in low-resource settings. The present paper aimed to develop a cost-effective surveillance strategy by analyzing the incidence and timing of fracture union with regard to associated factors and validating the squat and smile test as a screening tool. A review of the Sign online surgical database identified 128 patients with lower extremity diaphyseal fractures who underwent IM nailing in a trauma center from 2018 to 2021. Among the 128 patients, 80 radiographs were included for final analysis. The median follow-up after surgery is 12 months with a range of 8 to 32 months. Patient demographics, management, and outcome were retrospectively obtained from the service database upon approval by the IERB. Radiographs were reviewed using the institution's radiology information system, and all post-operative and subsequent follow-up radiographs were evaluated using the RUST. The time taken in weeks for a fracture to unite, defined as a total RUST score of at least 10, was recorded for each patient. Diagnosis of non-union was made when the total RUST score was at most 8 at the time of last follow-up. We then cross-checked using the Sign Online Surgical Database and identified 48 patients from the study cohort with squat and smile photos. We considered the squat and smile test to be positive for union when the images show squatting ability on lateral view with the patient smiling. A total of 80 patients were eligible to be included in the final population. 70 patients representing 87.5% of the population base were fully healed. The remaining 10 patients representing 12.75% exhibited non-union of their respective injuries. Our study identified a 4.28 rate of delayed union, with fracture consolidation at a range of 34 to 39 weeks after the index surgery. Baseline characteristics are described in Table 1. 12.5% of the 80 patients developed non-union, and the median interval from IM nailing to the detection of fracture union was 15 weeks. 33 femoral fractures and 9 tibial fractures united within 15 weeks of surgery, and the cumulative incidence at 12, 16, and 20 weeks were 41, 59, and 66% respectively. On univariate analysis of possible factors related to union, the patients who developed deep infection and had pain on weight bearing had significantly longer EFS, or longer fracture healing period, than patients without. To eliminate bias due to confounders, multivariate analysis was performed using the Cox proportional hazards model on the variables with a p-value of less than 0.1 from the univariate analysis. Pain on weight bearing was the only independent factor associated with development of non-union, with a relative risk of 10.5. To compare the utility of squat and smile tests as a clinical evaluation for union, we test for the specificity and sensitivity utilizing a 2x2 comprehensive matrix table. Out of the 80 people included in the study, 32 people were censored as having no squat and smile data. The average union rate after fixation with a rigid interlock intramedullary nail has to be as high as 93 to 97%. The prevalence of delayed union and non-union were at 6.9 to 7.5%. The present study reports a lower incidence of union at 87.5 and an increased non-union rate at 12.75. However, the data presented supports that the patients treated with the sign nail has a comparable union rate, and the data mirrors the current acceptable average weeks to union for a femoral or tibial shaft fracture. The optimal surveillance for fracture union, taking into account those who presented with delayed union and the predictors of union identified, is most likely to be effective in the initial 4 months after surgery. For patients presenting with pain on weight bearing or infection at the 4th month or more after surgery, a more vigilant surveillance for union and non-union should be employed. The squatted smile test is performed during the periodic intervals of follow-up with the surgeon, asking the patient to hold themselves in a squat position and then smile. The present study reports data that surpass those in current literature with sensitivity of 90%, a specificity of 100%, and a diagnostic accuracy of 92%. In conclusion, the squat and smile test could be a potential low-cost surveillance method for reliably detecting lower extremity fracture union, especially at 4 months from IM nailing. However, closer follow-up with radiographic surveillance seems necessary for patients developing superficial infection or pain on weight bearing. This clinical tool may be used by surgeons in monitoring the healing progress of patients that have logistical difficulties in complying with serial radiographic monitoring. It is particularly beneficial in the surveillance of union for patients residing in remote areas and those affected by the restrictions of the pandemic. Thank you.
Good day, everyone. I am Dr. Almar Bantolo of Western Visayas Medical Center. Today, I'll be presenting to you my research paper entitled The Incidence of Orthopedic Trauma Cases Managed in a Tertiary Hospital in Western Visayas during the pre-COVID and COVID period, a comparative study. I have no disclosure in the study. Coronavirus disease was initially reported in the World Health Organization on December 31, 2019. On January 30, 2020, WHO declared COVID-19 an outbreak of global health emergency. On March 11, 2020, WHO declared COVID-19 a pandemic. As of April 2021, there has been 145 million cases, 83.5 million recoveries, 3.80 million deaths, and such number increases every day. As June 2021, the Philippines ranks 25th worldwide in total of 1.36 million cases, 23,621 deaths,
and 1.2 million recoveries. The Department of Health created strategies and implemented minimum health protocols since the start of the pandemic. The Philippine government placed the entire country under a state of calamity for a 6 months period. The government started announcing local lockdowns, quarantines, curfews to barangays and cities and province following the increase of global coronavirus cases. The impact of COVID-19 in surgical practice is widespread, ranging from workforce and staffing issues, procedural prioritization, and biotransmission risk interoperatively, and changes to perioperative practice in ways of working alongside the impact of surgical education and training. On March 20, 2020, Jose Antonio Salud, MD, FPCS, President of the Philippine College of Surgeons, stated that to limit the surgical procedure to emergent and urgent cases only as a precautionary protection to health workers. On April 4, 2020, Paul Raul Camina, MD, FPOA, President of the Philippine Orthopedic Association, also stated orthopedic surgeons should perform urgent or emergent surgery, or in the case that are not life or limb threatening but needing early care to prevent major complication, may be classified as an urgent in nature. Among the significant changes encountered during the pandemic were decreased trauma cases in each training institution, strict quarantine lockdowns, curfews in each barangay, implementation of liquor ban in provinces and cities, decrease in hospital beds due to the conversion of institution to COVID center. Such impact effects in each training institution on their adaptation, strategies, and changes to comply with the requirements set by the Philippine Board of Orthopedics. The objective of the study is to determine the difference in incidence of trauma cases during the pre-COVID versus the COVID period in the tertiary hospitals in Western Visayas. Specifically, to determine the incidence of trauma cases during the pre-COVID versus the COVID period in three orthopedic training institutions in Western Visayas, namely Western Visayas Medical Center, Western Visayas State University Medical Center, and Corazon Ocsin Montelibano Memorial Regional Hospital. Also, to determine the incidence of trauma cases monthly during the pre-COVID and versus the COVID period in three orthopedic training institutions in Western Visayas. More specifically, to determine what changes in coping strategies were done by each orthopedic institution, to determine the effects of the pandemic in their training program during the pre-COVID and COVID periods. The significance of this study will benefit both the training institution and the Philippine Board of Orthopedics. This will show the real picture of the effects of the COVID-19 pandemic in each training program on their adaptation to comply the requirements set by the PBO. This will also serve as a guide for the PBO to reevaluate and reconsider the requirements set by the PBO in each institution with regards to the training program during the pandemic. This study is a multi-center descriptive cross-sectional study involving three orthopedic training institutions in Western Visayas, namely Western Visayas Medical Center, Western Visayas State University Medical Center, and Corazon Ocsin Montelibano Memorial Regional Hospital. This study was conducted from July 2021 to September 2021. Our study population include all trauma cases and orthopedic training institution in Western Visayas, namely Western Visayas Medical Center, Western Visayas State University Medical Center, Corazon Ocsin Montelibano Memorial Regional Hospital during the COVID period and the pre-COVID period. All trauma cases operated both major and minor and are logged in the PBO logbook are included in the study, while hand, pedia, and spine cases admitted or co-managed by another department in each institution are excluded in this study. In this study, the data was gathered during the pre-COVID and COVID period. Primary investigator asked permission from the Philippine Board of Orthopedics to access all trauma census logged by each training institution and the Philippine Board of Orthopedics e-logbook in the years 2020 and 2019. Monthly trauma cases and overall cases are from the years 2019 and 2020 from the three programs after approved by the PIBO and respective institution are gathered. A questionnaire sent to the chairman and training officer in each institution with regards to the effects, strategies, adaptation done to comply with the PBO requirements. All data are extracted from the PBO logbook were tabulated and analyzed using a statistical tool. In this study, the number of trauma cases during the COVID and pre-COVID period in three research training centers, namely Western Visayas Medical Center, Western Visayas State University Medical Center, and Corazon Locsin Montalibano Memorial Regional Hospital were considered. The distribution of cases was compared through percentage difference and through statistical tests. The monthly data on this distribution of the cases were also included in the analysis. However, no statistical test was done to compare the distribution of cases due to incomplete pairing of the months and probably seasonality of trauma cases. Presented in Table 1 were the number of trauma cases during the pre-COVID and COVID period with the corresponding percent differences and significant values. Out of the three training institutions, only the Corazon Locsin Tolibano Memorial Regional Hospital had an increase of more than half in the number of trauma cases during the COVID period compared to the pre-COVID years, while the other two, the Western Visayas Medical Center and the Western Visayas State University Medical Center, decreased by more than half or one-fourth. All of these institutions have significant difference in the distribution of trauma cases between the pre-COVID and COVID period. Overall, accounting for all three training institutions, a decrease by 2.715% in number of trauma cases was recorded, which was recorded as not a significant difference in terms of distribution. As shown in Table 2, monthly number of trauma cases in the three training institutions varied. Notably, a slump of cases was observed during the months of May, November, September, and October. On the other end, the rise of cases were observed in the early months. Comparing all in all, the 12 months, the distribution of trauma cases for the months before and during the COVID period were observed to be not insignificantly different. This result can be attributed to the increase of cases in the early months, which balanced the decrease of cases in the later months. Succeeding slide will show you the overall total and monthly trauma cases on three training programs for years 2019, which was gathered from the e-logbook, also in 2020. Comparing the total number of trauma cases in each training institution, both the Western Visayas Medical Center and the Western Visayas State University Medical Center showed decreased cases compared to the Corazon Locsin Montalibano Memorial Regional Hospital. Based on the graph, monthly and cases in 2019 compared to the monthly trauma cases in 2020, data showed that there was a decrease in trauma cases effectively. In Iloilo City, where both Western Visayas State University and Western Visayas Medical Center are located, the decrease in trauma cases was brought about by quarantine guidelines set by the IATF, curfew hours, and liquor ban in both provinces and the city. With existing 9 hospitals, both private and government hospitals, including the Western Visayas Medical Center and the Western Visayas State University Medical Center in the city, and the other secondary hospital in the province, such trauma cases are being spread to this hospital. Only tertiary cases are being transferred to the city. In Corazon Locsin Montalibano Memorial Regional Hospital, increase of trauma cases in their institution may be due to all trauma cases are being brought in their institution directly. One factor may also contribute to the increase of census on a different institution is that the efficacy of each training institution to register or log their cases in the PBO e-logbook. As part of the requirements of the PBO, since all data gathered are based on the actual census registered in the e-logbook for each residence in each training institution. With such changes in trauma cases, adaptation and strategies done by 3 training institutions, Western Visayas Medical Center created its Operation Dagyao, wherein a memorandum of agreement was created with other government hospitals in the province to allow residents to do surgery. The Western Visayas State University Medical Center followed strict guidelines of Infectious Control Committee, thus limit its service to cater extreme emergency only, while the Corazon Montalibano Memorial Regional Hospital established an online consultation for other patients. Under strategy, the WBMC continued Operation Dagliao and created a memorandum of agreement to a private hospital to allow residents to do surgeries under supervision of its training consultant. The Western Visayas State University Medical Center created e-consult for follow-up and cater new patient, where the Corazon Locsin Montelibano Memorial Regional Hospital continued its adaptation because they have sufficient amount of cases being the center of trauma cases in the Negros Occidental. For the conclusion, COVID-19 affected the way of life of people in the society and changed everything from social gathering to community quarantine. Restrictions and quarantine protocols decreased the incidence of trauma cases, in which in turn affect the census of training institutions except for the Corazon Locsin Montalban Memorial Regional Hospital. Different adaptations and strategies were done to meet the cases for each resident as required by the PBO. For future recommendation, future studies should include other specialties besides trauma to see the full impact of COVID-19 in the variety of cases of each institution. Thank you, God bless, and keep safe.
Good morning. I'm Christian Fontanilla from East Avenue Medical Center, here to present a retrospective cohort study on using fully threaded cortical screws for locking sign intramedullary nails. The sign system from the surgical implant generation network utilizes a solid straight nail with a proximal bend for femoral or tibial fractures. The threads of its interlocking screws are concentrated at the neck and at the tip to purchase at the near and far cortices, as shown on the image on the right. When sign interlocking screws are unavailable, 4.5 mm fully threaded stainless steel cortical screws may be used to lock the nail, a sample of which is shown on the lower right. This study compared the fracture alignment, fracture healing, and screw failure rates between using solely sign interlocking screws and incorporating fully threaded cortical screws. The method of this study was to review the sign census from January 2018 to August 2021. Cases were grouped based on locking screws used, and the characteristics of these cases in terms of fracture alignment, fracture healing, and screw failure were noted. The chi-square test of independence was used to determine difference in outcomes between the two groups. 153 cases were identified, 79 of which were included in this study. 59 used solely sign interlocking screws, and 20 incorporated fully threaded cortical screws. Majority of these cases came from the 18 to 59-year-old age group. Majority were male, and most involved femoral fractures. Of the 59 cases which used solely sign interlocking screws, 91.5% showed acceptable alignment, 81.4% showed 3 to 4 bridging cortices within 12 weeks, and 3.2% showed screw failure. Among those which incorporated fully threaded cortical screws, 90% showed acceptable fracture alignment, 80% showed 3 to 4 bridging cortices within 12 weeks, and 5% showed screw failure. With these p-values, the chi-square test of independence showed no statistically significant difference in outcomes between the two groups in terms of fracture alignment, fracture healing, and screw failure. Incorporating fully threaded cortical screws to lock sign nails proved fully useful during the COVID-19 pandemic, when shipping restrictions prevented replenishing of the limited sign interlocking screws inventory. Locking intramedullary nails with fully threaded cortical screws was first discussed in 1990. AO found that by maximizing screw-cortical bone contact and by ensuring that the screw diameter is less than 50% of the nail diameter, screw failure could be avoided. With this, the study concludes that fully threaded cortical screws may be used to lock sign nails with no significant difference in outcomes compared to using sign interlocking screws in terms of fracture alignment, fracture healing, and screw failure. This study can be improved by discriminating outcomes based on the number of fully threaded cortical screws incorporated and by including a larger sample size. The following were my references. Thank you.
Everyone, I'm Dr. Lauren Albervillo and I'm presenting our study entitled Comparison of Revision Rates and Complications of Total Knee Arthroplasty between Filipino octogenarians and their age appropriate controls. Osteoarthritis is a degenerative condition affecting various joints of the body and is known to be one of the leading causes of chronic disability among the elderly. To date, total knee arthroplasty or TKA is the only definitive treatment for end-stage knee arthritis. The highest volume of TKA is performed among patients aged 65 to 74 years. On the other hand, the overall prevalence of osteoarthritis in persons aged more than 18 years, or the octogenarians, is estimated to be 17.7%. Despite the relatively small percentage occurring in the more elderly group, several authors have projected that the number of elderly patients undergoing TKA will increase exponentially as the population over the age of 65 doubles by the year 2050. Local data shows that as of 2015, only 8% of the Filipino population belong in the senior citizen group. From 2025 to 2030, older Filipinos aged 60 years and over are projected to account for at least 10% of the total population. This increasing trend is expected to continue over the coming years. Although TKA can successfully alleviate pain, restore function, and improve patients' overall quality of life, in the more elderly age group, it may also be thought to be associated with several risks as they tend to develop more medical comorbidities and require more medications. Some authors propose that the risks of developing intra-op and post-op complications may be potentially higher as well. And so this study aims to describe the complications and revision rates of Filipino octogenarians who underwent elective TKA and compare it to their age-appropriate controls. Specifically, these are our objectives. No local data has reported revision rate and complications of elective TKA in the Filipino octogenarian. More significantly, data gathered may be helpful in guiding orthopedic surgeons in patient selection. Basing from the surgical census from January 2011 to March 2021, all patients who underwent elective TKA were included in the study. Each were classified into either of the two groups based on their age at the time of surgery, while patients established to have the following were excluded. Demographic data and preoperative comorbidities were obtained from the hospital records. Data recording total length of hospital admission, blood transfusion, revision surgery, 90-day mortality, readmission, and complication were reviewed from hospital database. A total of 58 subjects were included, of which 26.3% were classified under the octogenarian group with a mean age of 82 years, while 74% belonged to the non-octogenarian group with a mean age of 60. Majority were female, and in terms of BMI, majority were obese. Majority were preoperatively assessed as Class 2 American Society of Anesthesiologists classification. Both groups were similar with respect to sex, BMA, and ASA classification. Among all patients, majority or 60% had a history of hypertension, while a smaller percentage had diabetes. Comparing the two groups, neither of these comorbidities is significantly different between the two groups. In general, all patients had an average 7.3-day hospital stay. Octogenarians stayed for an average of 6.57 days, while non-octogenarians stayed for an average of 7.7 days, which is statistically not different. Only 18.9% of the total population received blood transfusion. 33.3% of the octogenarians had blood transfusion versus only 13.9% among the non-octogenarians, which was not statistically different. Among the 58 patients, only one patient underwent revision surgery, and this was due to infection. This patient belonged to the octogenarian group. On further analysis, the probability of the occurrence of revision is more likely to occur in the octogenarians. Further, the log rank test concludes that there is a significant difference. Overall mortality was 0%. There were only 2 readmissions, both from the octogenarian group. On further analysis, the probability of the occurrence of readmission is more likely to occur in the octogenarians, while the log rank test shows a significant difference. Only one patient developed DVT and 2 patients developed pneumonia, both from the octogenarian group. No complications were recorded from the non-octogenarian group. Filipino octogenarians who underwent TKA are seen to be comparable to their younger counterparts in terms of their pre-op medical status. In our study, octogenarians had a higher incidence of blood transfusion with an average of 2 units packed RBC. This result, however, was not statistically significant. Also, in our study, despite the higher incidence of blood transfusion in the older group, this did not lead to an increase in length of hospital stay. Generally, results of the study show that the overall complication rate within 90 days from TKA is low, as follows. However, all these complications are seen in the octogenarian group. In terms of mortality, none of the patients has expired. In conclusion, TKA has an overall low complication rate even among the Filipino octogenarians. There is no significant difference in terms of blood transfusion and length of hospital stay. However, a significantly higher revision rate and readmission within 90 days from surgery is observed and should be discussed preoperatively with Filipino octogenarians. These are our limitations. Thank you very much.
Transforaminal lumbar interbody fusion along with transpedicular fixation has been a well-established method for lumbar spinal fusion for patients with degenerative spine disease. Fusion success is dependent on the type of instrumentation and bone graft material. The bone graft material should possess good mechanical strength and inherent osteogenic capacity. Numerous studies have reported comparable fusion rates for the use of iliac bone and local bone obtained from decompression. These studies, however, utilize morselized local bone graft. Good afternoon, I'm Josiah Navarro, and I'll be presenting the functional and radiographic outcomes in patients who underwent transforaminal lumbar interbody fusion using posterior instrumentation, autologous inferior articular facet bone block with polyether-ether ketone cages, and morselized autologous bone graft. The major objective of this study are as follows. We evaluated all patients, male and female, who underwent transforaminal lumbar interbody fusion from January 2017 to December 2020 of writing at both St. Luke's Medical Center, Quezon City, and Bonifacio Global City, and these are the inclusion criteria. The exclusion criteria are as follows. Demographic, clinical, and pre, intra, and postoperative information will be determined from patients' medical records at both the hospital and surgeons' clinics. All patients who met the inclusion criteria were included in the study. A total of 20 patients were included, and only 14 patients provided consents, and only 6 patients had radiographs done a year after their opening. All surgeries were performed by the two co-authors of this paper. The spines process, lamina, facet, and facet joints were exposed routinely via paramedian approach. The pedicle tract from the desired lumbar levels were identified. Preliminary wires were applied under C-arm guidance, and then this is followed by decompression via laminotomy or laminectomy and partial inferior articular facetectomy, outlined using a high-speed burr. They are taken as one piece by undermining the edges with a curved curette, and as seen on the figure 1. The superficial ligamentum flavum is then excised until the dura is exposed, and the nerve roots are decompressed. The nerve root is then gently retracted to expose the disc in annulotomy, followed by discectomy, and the end plate preparation is done. The polyether-ether ketone cage sizer is then determined and checked by image intensifier. The inferior articular facet obtained as a bony block, as seen on the second figure, is then denuded and prepared according to the size of the peak cage height. And it is then inserted into the anterior aspect of the intervertebral space as seen on the third figure. The appropriately sized peak cage with morselized local bone graft is then inserted posterior to the sentinel graft as seen on the last figure. This is done to the affected lumbar vertebral levels, after which appropriately sized pedicle screws are applied, followed by drills. The Oswestry Disability Index is a patient-reported outcome measure which provides a percentage of the level of function or disability in the activities of daily living in patients suffering from acute or chronic back pain. The questionnaire examines perceived level of disability and 10 activities of daily living. These 6 statements are scored from 0 to 5. The higher the score, it correlates to the greater disability. According to Fairbank et al., the ODI remains a valid and vigorous measure and has been a worthwhile outcome measure. In their study, 4 ODI versions has an acceptable internal consistency, and in our paper, ODI was obtained pre and at 1 year post-operatively. The tailored index is a radiographic measurement for the degree of slippage and its reduction for patients with listhesis. But for this paper, we wanted to determine whether the facet joint that contained the strut autograph exhibited anterior interbody support. the immediate post-op and then 1 year post-operative anterior disc and posterior disc heights, as represented by the ADH and PDH, were measured with lateral lumbar radiographs obtained with the subject in the upright position. Fusion was also assessed radiographically using the criteria for a radiographic bony fusion, of which at least 3 would have to be present: trabecular structure appearing in the bone graft, bony bridging anterior to the cage, lack of radiolucent lines around the graft, and bony continuity between the upper and lower end plates. Anterior fusion was then assessed using a 4-point grading system as follows. For the demographic and clinical profile, these are the profile of our patient. The mean Oswester Disability Index scores of the patients preoperatively and postoperatively are 37.78 and 9.5 respectively. Comparative analysis showed that the mean preoperative Oswester Disability Index scores and postoperative scores were statistically different. For the tailored index, it can be noted that the comparison between the anterior disc height and the posterior disc height immediately post-operation were statistically different, as well as the anterior disc height and the posterior disc heights at 1 year post-operation. The comparison of the anterior disc height immediately and post-operation at 1 year was not statistically significant, although the comparison between the posterior disc height immediately post-op and 1 year was statistically significant, as represented by the table on your figure. For the anterior fusion grading, all of the participants achieved successful fusion graded 1 to 3, 50% for each grade. Analysis between the anterior fusion grade for bony union and ODI scores noted to have correlation, but due to the small number of participants is not statistically significant. Iliac bone graft remains the gold standard with an excellent biological healing ability, allowing for better fusion rates for TLIF. Obtaining this graft, however, produces complications such as pain, bleeding, infection in the area of the graft site, and also increases operation time. The use of an allograft has similar biological healing ability of an autograft, but there is a degree of immunogenicity and potential risk for spreading infectious disease. The posterior decompression laminectomy and the facet joint may be used as TLIF graft material. These materials provide good clinical outcomes and help prevent complications by using the ileum. Outcomes of this novel technique wherein instead of morselized autologous bone graft or iliac bone graft, the denuded inferior articular facet tapered to its appropriately sized was utilized. The results of our study cannot be generalized due to the small number of participants, and there were no intraoperative complications for all of the participants. The participants in our study were operated for degenerative spondylolisthesis. The functional outcomes revealed to be good to excellent with improvement in ODI except for one patient. The union rate for patients with radiographs at 12 months follow-up revealed to be 100%, with anterior fusion grades of 1 to 2 at 50%. Majority of our patients were male, while only 28.6% were female, which negates a gender predominance found in studies for degenerative spondylolisthesis. Our mean ODI for this study are comparable with that of Kakadia et al., with a mean preoperative ODI of 38.7 and 21.3 postoperatively. Both our studies included mainly of degenerative spondylolisthesis. In determining the effectiveness of the inferior articular facet bone block, we utilized the tailored index, measured the anterior as well as the posterior disc heights immediately and at 1 year post follow-up for each vertebral level fused. This measurement allowed us to gauge the degree of subsidence for the inferior articular bone block graft and the polyether-ether ketone cage with morselized bone graft, since the placement of the sentinel bone block graft is anterior to the peak cage. As the results revealed, the comparison for the anterior disc height at immediate and at 1 year post-operation revealed no significant difference, while the comparison for the posterior disc height at immediate and at 1 year post-operation noted to have significant difference. These are the limitations of our study and thus the recommendation for this study. For our conclusion, TLIF using inferior articular facet bone block with PKH has a promising results in achieving satisfactory functional outcomes in bony union in the treatment of degenerative lumbar spine disease. Thank you.
Good day. I am Dr. Ritesh Pokhrel, and I'm here to present my research titled A Review of Clinical Outcomes in Children with Club Feet Treated with Ponseti Method, a Single-Centered Study. With an estimated global prevalence of 0.6 to 1.5 case per thousand birth and 0.76 per thousand locally, congenital telepe echonovirus is one of the most correctable congenital orthopedics, correctable structure birth defect. Idiopathic CTBE is the most common and is an isolated deformity of one or both feet. It always consists of four components: the equinus, the hindfoot, varus, forefoot adductus, and cavus of the midfoot. If not treated successfully, it can progress to a severe lifelong disability. With a goal to reduce, if not eliminate, all element of the clubfoot, hence living a functional, pain-free, normal-looking, plantigrade, mobile foot, the deformity is corrected in sequence as such: cavus, adductus, varus, and finally the equinus. Various articles about clubfoot and the treatment methodology, particularly the Porcetti techniques, were reviewed. Porcia et al. Conducted a study in 49 infants with 67 club feet. Most of the cases were unilateral with right foot predominance. Success rate of Ponseti technique was 100%. Similarly, Lehman et al. Showed excellent early results with Ponseti technique, and a study by Ponseti showed the average number of casts with Ponseti technique was 5.4 compared to kite techniques, which was about 20. Our study sheds some light in the effectiveness of Ponseti method, as well as the greater understanding of the case of clubfoot in our institution. Similarly, recognizing of important risk factors for failure recurrence may eventually result in better patient selection for the current available treatment of clubfoot, and may allow early intervention to improve complications and outcomes in not just our institution, but in the nationwide clubfoot treatment program. These were my general objectives and my specific objectives. Only patients diagnosed with congenital talipes equinovarus by an orthopedic surgeon or seen in our institution or the Miracle Foot program, regardless of the age, were included. Foot deformity not attributed to CTEV and incomplete treatment or unknown outcomes were not included. After the approval of Institutional Technical Review Board and Ethical Review Board, we reviewed the patient's chart retrospectively, where 21 patients with 29 feet treated by Ponseti method in our Miracle Feet Clinic during the period of January 2019 to December 2021 that met the inclusion criteria were included in the study by a purposive sampling method. Medical charts record and mobile applications of Miracle Feet program was accessed and data were collected. And these are our results. 61% had unilateral involvement, in which 53.84 was the dominant right. 85.71% were male, and the male to female ratio was 6:1. 47.62% were less than 3 months, and 33.33 were 6 months or equals to 6 months. Overall population, irrespective of the age, had mean Pirani score of 3.86 at the time of treatment initiation. The mean score is higher in the less than 3-month age group compared to the older group. Similarly, the mean Pirani score before tenotomy was 1.68. The mean number of total cast session was 6.79 for the overall population, irrespective of the age, and the cast session was noted to be higher in the less than 3 months age group compared to the older groups. This table further shows the breakdown of total number of cast session in different age group. The overall tenotomy rate was 72.41%, and 95% of our patient population had undergone bracing. We had one surgery and one complication, as in terms of blisters. We were not able to, there was no recurrence. The mean duration of treatment or follow-up was 28.98 weeks. And we came to our conclusion that overall early success rate of Ponseti technique, including manipulation, serial casting, and tenotomy was 96.55%. The complication rate was 3.45%, and the low rate of failure and complications highlighted the effectivity and safety of Ponseti technique in the correction of clubfoot deformity in local setting. These were our limitations, and we recommend further study with more patients in the subsequent year, longer duration of study to assess the long-term effect and the functional outcome, a prospective study to eliminate information bias, and various other characteristics like socioeconomic status, educational level of the parents may be included in the further study. These were my reference. Thank you.
Good day, colleagues. I'm Tristan Dwight Sebastian, a fourth-year orthopedic resident from Philippine General Hospital. And I'll be presenting the paper entitled Characteristics, Treatment Patterns, and Clinical Outcomes of Patients Presenting with Fungating Extremity Soft Tissue Sarcoma. Lumps and bumps are not unusual in patients presenting to a musculoskeletal tumor service. Management guidelines are available. However, there will be those unforgettable times that you will see and even smell large fungating soft tissue tumors, a situation distressing both the patient and physician. The question remains whether fungation carries a poorer prognosis, if it is better treated with amputation, and if limb salvage surgery is possible. We undertook this series to better define their demographics and see if we could find initial answers to these queries. Fungation occurs when the tumor erodes the skin surface and grows outwards like a fungus. Surprisingly, there are only 2 studies that describe fungating extremity soft tissue sarcoma. The clinical characteristics, treatment, and outcomes of these cases are not well established. The cases are usually patients that have been managed inappropriately or have had a delayed course of consult. By observing their clinical profile and treatment patterns, we can obtain knowledge and improve the decision-making process in order to maximize survivorship and limit morbidity. For this research, we asked, what are the clinical characteristics, treatment patterns, and outcomes of surgically treated fungating extremity soft tissue sarcoma patients? Our objectives are the following. The clinical characteristics are described in the following variables. The treatment will be described with these variables. R0 is clear margins, and R1 is microscopically positive tumor margins. Outcomes will be described in terms of survival, local recurrence, metastasis, and complications. We reviewed the patients treated by the senior investigator over a period of 25 years, with the following inclusion and exclusion criteria. The senior investigator managed 258 cases. 28 had a fungating mass. We have a crude incidence of 10.9%, higher compared to the study of Parry et al. With only 3.2%. 8 patients were excluded. Finally, we have 20 patients for this series. Results were interpreted with descriptive statistics. The mean age was 49 years old, with no gender preference. The tumors were 12 centimeters, usually located in the thigh. Majority of the tumors were deep to fascia and high grade, which are consistent with an aggressive nature of fungating tumors. The 3 most common histologies were liposarcoma, MPNST, and rhabdomyosarcoma. More than half of patients had unplanned excision of their tumor by another surgeon. The residual tumor, postoperative inflammation, and presence of an iatrogenic break in the skin most likely contributed to conditions favorable for fungation. 2 patients had undergone biopsy at another hospital. 2 patients had metastasis at presentation. Limb salvage surgery was done in 12 patients, while 8 had amputation. 3 of those who underwent limb salvage surgery had R1 margins. Post-operative radiotherapy was given. 2 were initially non-metastatic patients but developed local recurrence and distant metastasis. Both died of disease in less than a year. The amputation rate for our series was 40%, higher than 28% rate for soft tissue sarcoma in the local setting, and was almost twice that in literature. It would seem that oncologic outcomes of both limb salvage surgery and amputation groups were almost similar. The oncologic principle of doing limb salvage surgery for soft tissue sarcoma still applies, regardless of whether a fungating lesion is present. Prior to 2010, Amputations were almost exclusively undertaken due to fear of tumor leakage and contamination. Over the next decade, it would seem there is reversal toward limb salvage surgeries. Half the patients had surgical reconstruction, by skin graft, or flap coverage. Two patients had surgical site infection and wound dehiscence, and one had wound dehiscence alone. Five patients with deep and high-grade tumors were given radiotherapy, and four patients were given chemotherapy. In summary, our series had a younger age group with larger and mostly deep tumors. Most common tumor histology differed across studies. The high-grade nature of fungating tumors were common in all studies. Outcome-wise, we have higher local recurrence and distant metastases, but mortality from disease across the studies were similar. Based on this series, the clinical characteristics of fungating extremity soft tissue sarcoma are the following. Treatment-wise, limb salvage surgery was possible. Adjuvant RT was given to those with R1 margins. Over the last 10 years, there have been a preference of limb salvage surgery over amputation. 25% of 25% of patients had local recurrence. 65% had distant metastasis on follow-up, and 60% died of disease with a mean time to death of 21 months from diagnosis. Those who survived had a mean follow-up of 7.6 years. It would seem, therefore, that a long disease-free survival is possible despite fungation as long as we adhere to the principles of oncologic management. Limb salvage surgery is possible as long as we adhere to the principles of oncologic surgery. There may be room to improve local control rates by lowering the tolerance for administering RT. These are the cases of high-grade tumors regardless of them. Given the limited volume of soft tissue sarcoma patients and the inherent limitations of a retrospective study, we recommend prospective and collaborative studies involving other institutions and surgeons. Here are our references. Thank you very much for listening, and may you all have a great day.
Degenerative disease of the lumbar spine is a significant cause of disability in the world, encompassing a variety of symptoms, including lower extremity pain, weakness, and low back pain of varying levels of severity. In a study in 2018, it has been shown that 266 million individuals suffer yearly from the disease worldwide, leading to an impaired quality of life. Current therapeutic options consist of conservative measures of physiotherapy, analgesia, and epidural steroid injection, or invasive lumbar surgery, traditionally bilaminectomy. Spinal decompression has been shown to improve the symptoms of back and leg pain among patients effectively by relieving the local stenotic pathology. Several studies, such as the Spine Patient Outcome Research Trial or SPORT, have demonstrated sound evidence that point towards superior results of surgery compared to conservative measures. Decompressive laminectomy has been one of the mainstays of treatment of lumbar spinal stenosis. However, it's not without its limitations, suggesting a potential for progression of instability. Thus, in the background of this potential instability, the gold standard of treatment has been determined to perform spinal fusion, which results in the increase in stress of concentration and range of motion of your adjacent segments in the fusion segment, causing such issues such as pseudojoint formation, ectopic ossification, and adjacent segment degeneration and other complications. To address these limitations and disadvantages associated with fusion, novel techniques and implants with motion preservation, such as your interlaminar device, following decompression, has gradually gained the attention of spine surgeons. Coflex interlaminar device focuses on decelerating the degenerative process through dynamic stabilization of the lumbar spine to provide adequate stability for restoring normal segmental kinematics, which allows for more physiologic load transmission. The effectiveness of the use of Coflex as an alternative in the treatment of degenerative lumbar disease has been well established in literature. Articles which report on its outcomes, however, only go up to as far as around 4 years. Validation of the sustainability of this device, therefore, is recommended to be conducted in terms of a long-term follow-up for which this study aims to provide. Good morning, doctors. I am Ana Francesca Ambrobles. I'm here to present my study entitled Coflex Interlaminar Stabilization and Decompression for lumbar spinal stenosis, a 7-year clinical follow-up and assessment. This study was developed in order to validate the clinical outcomes and effectiveness of the application of Coflex in adjunctive decompression for degenerative lumbar disease through a long-term or 7-year follow-up in a single tertiary center with the following specific objectives. This study is a retrospective review of patients who underwent lumbar decompression with concomitant placement of Coflex device for diagnosis of degenerative lumbar spinal stenosis, lumbar disc herniation, and lumbar disc herniation. We included patients who underwent the procedure dating from January 2010 to December 2013 with a duration of follow-up of at least 8 years with appropriate consent in obtaining data. The list of patients were selected from the Institute of Orthopedics and Sports Medicine patient census who underwent the said procedure, and it was done by a single surgeon and screened for eligibility. The inclusion and exclusion criteria as follows, as shown in this slide. All operations were done under general anesthesia, with patients playing in a prone position on a well-padded Wilson frame. Surgical exposure involved a midline longitudinal incision, followed by dissection of the paraspinal muscles. Standard decompression was carried out by laminotomy and foraminotomy, removal of ear ligament of flavum, and discectomy if applicable. Confirmation of decompression was performed under an operative microscope and to visualize the traversing and exiting nerve roots. After lumbar decompression, the interspinous ligament of the same level was removed and appropriately sized Coflex device was measured during trial sizers and inserted with the actual device thereafter. The Coflex is inserted in the interlaminar space in between the two spinous processes and its swings tightened using a clamp. Their closure was then performed and patients were then allowed to sit up and ambulate as tolerated post-operatively. The Oswestry Disability Index, ODI, a 10-point visual analog scale for back pain and leg pain were obtained and used as a basis to assess the clinical outcomes of the following time points: preoperatively, 2 years post-op, and the final follow-up of around 7 years. The ODI recovery rate represented the degree of normal functioning after surgery and was calculated as follows. The degree of recovery was then rated as either excellent if there's more than 50% of improvement, good if there's improvement between 25 to 50%, fair if there's a change of 25% in the ODI, and poor if there's a decrease of more than 25% in the ODI. Meanwhile, a decrease in the VAS score of at least 2 was likewise considered a significant improvement. Statistical analysis was carried out using the IBM SPSS software, and data were presented as means and with the standard deviation and frequency. The ODI and the VAS scores were then compared at the different time points of follow-up and evaluated using a paired sample t-test with a statistical significance of less than 0.05. The results are as follows. Here would be the demographic data that was obtained. So we analyzed a total of 16 patients, 11 men and 5 females, who had an existing diagnosis of the degenerative lumbar disease, confirmed via X-ray and MRI, presenting with symptomatic back and leg pain. The mean age is around 48 years old with a range of 31 to 80, with a higher percentage of male participants. The mean overall score for the ODI pre-op was around 41.8, with a standard deviation of 11.9, while the pre-op VAS score was 5.79, and the pre-op VAS for the leg pain was 5.94. The mean operative time for these patients took around 183 minutes and average blood loss of 244 ml. Clinical evaluation was performed using the VAS score in ODI, which was shown to improve pre-operatively to post-operatively. As you see, the ODI scores at different time points showed improvement in the score with statistical significance at short and long-term follow-ups. The VAS score for the back pain also showed the same results, showing significant improvement in score at short-term follow-up, but no difference thereafter in the long-term follow-up. For the leg pain, showed also significant improvement in the short-term follow-up, with no significant difference at the long-term follow-up. The recovery rate in ODI score and improvement in VAS scores for the leg and back pain exhibited good results in both groups at the final follow-up of 7 years. which showed excellent recovery in majority of these patients and clinically significant decrease in the VAS score, defined again as more than 2 points in difference from the baseline. Paired t-tests were used to compare for the patient-reported outcomes at baseline for the first follow-up at 2 years, then in comparison to the final follow-up at 7 years. Comparing with the baseline, both ODI and VAS scores at 2 years post-op generated p-values well within the cutoff of less than 0.05, stating statistical significance in terms of reported pain scores at these time points. The same results were also obtained when comparison of clinical outcomes were analyzed on the final follow-up, except for the VAS score at 2 years and 7 years post-op, which showed a value of 0.216. Thus, the results of the current study were able to show that the short and long-term follow-up of these set of patients showed a significant improvement in terms of ODI and VAS score for the back and leg pain compared to the baseline. Literature review in the outcomes of those with studies in the 4 to 5 years showed comparable clinical outcomes with lumbar fusion surgery in the treatment of your lumbar degenerative disease. It has been shown in the same study that there is a marked improvement of the back and leg pain, which was maintained in the same time frame of the follow-up. There were no complications that were reported, such as loosening, displacement, and shedding of the coflex within this set of patients. And there's no also reported fractures or ruptures of the spinous processes in the same pool of patients. In summary, we found that the laminar decompression combined with the coflex interlaminar process device relieved patient symptoms, and long-term efficacy was also found to be satisfactory. Here are my references, and thank you for your kind attention.
Metastatic bone disease poses a high risk for skeletal-related events, including pathologic fractures and spinal cord compression, which lead to higher mortality after definitive surgery. Estimation of survival is important in treatment of metastatic pathologic fracture to help set patient, family, and physician expectations on prognosis. Good day, I am Katrina Naraval, here to report on the survival analysis of patients with pathologic fracture from metastatic bone disease in a single tertiary center. The presence of a pathologic fracture leads to a higher mortality rate after definitive surgery. Estimation of survival is important in treatment. Among the different hematologic and serologic parameters previously studied, hemoglobin, absolute lymphocyte count, and serum albumin are those that have shown significant results. Preoperative anemia is a strong negative prognostic factor and an indicator of survival in MBD. Low ALC indicates poor wound healing and higher morbidity in postoperative patients. Low preoperative albumin status has been correlated with poor postoperative recovery, with a significance in predicting cancer survival and in prognostication in patients. With local ethics committee approval, we conducted a retrospective cohort single tertiary center study involving patients diagnosed with pathologic fractures of the axial and appendicular skeleton, treated surgically and non-surgically between 2010 to 2020, and evaluated for hematologic and serologic risk factors for mortality. It included adult patients who were assessed with a diagnosis and who satisfied the inclusion criteria. A purposive data collection was done by going through the daily ward census, searching for keywords including metastatic and pathologic with the following algorithm. The mean age of respondents was 60 and mostly were females. Comparative analysis indicated that the mean age of the respondents who expired was significantly higher than those who were alive. The primary malignancy was found to be most common in the breast, followed by the lung and the kidney. And in patients with lung cancer, the proportion of those who expired was significantly higher. Pathologic fracture was more common in the spine than in the extremities. It was noted that those who expired within the first 6 months from the time MBD was established comprised of those with low preoperative hemoglobin, low ALC, and low serum albumin, as compared to those who expired within 1 year. This, however, were not statistically significant. Those who survived beyond 1 year, only 1.75% have normal albumin, and this is due to the study population's low albumin levels, which shows that despite a low albumin level, survival rates did not differ significantly. In terms of surgery, results show that 85.16% of the respondents had surgery, and the proportion of patients who survived within 6 months and had surgical intervention was not significantly different than those who expired and had surgery. Preoperative or postoperative chemo or radiotherapy, as well as the site of visceral metastasis and presence of other bone metastasis, did not have significant impact. 40.63% of the respondents expired within 6 months, while 14.84% expired within 6 to 12 months. And the median mortality time for patients with low markers was within 6 months. Cox proportional hazards regression analysis of the predictors of mortality showed that the adjusted hazard ratio of mortality among those without surgery was 25% higher among those with low preoperative hemoglobin and low ALC than those with normal values. In addition, results indicated that low serum albumin was not associated with the hazard of mortality among those without surgery. On the other hand, results reveal that adjusted hazards for mortality among those with surgery with low preoperative hemoglobin, low ALC, and low serum albumin were 31, 20, and 45% higher respectively than those with normal serologic results. Nevertheless, these results were not significant. The time from diagnosis and/or surgical intervention to mortality was earlier among those with low preoperative markers and those without surgery. The common significant risk factor of survival across all studies is the site of primary cancer leading to pathologic fracture, and this relationship between primary site of malignancy and long-term survival in patients with pathologic fracture has been well established. Preoperative serum albumin, lymphocyte counts, and hemoglobin levels were all found to have a higher risk of mortality in this study, however, not statistically significant. Although other reports have showcased preoperative hemoglobin level as the only independent predictor of survival, preoperative serum albumin has also been reported as an independent prognostic factor of survival in MBD from various malignancies, and ALC is reported as an independent predictor of survival in MBD in the femur. However, not one study reported all as a significant risk factor for mortality in metastatic bone disease. And these findings may be due to the fact that most of the patients diagnosed with MBD with concomitant pathologic fracture already represent the terminal stage of the disease. No significant difference in terms of mortality was found between the operative and non-operative group. These findings again reflect those patients are already in the terminal stage of the disease owing to its low survivability. In conclusion, primary tumor site is an independent prognostic factor of survival in patients diagnosed with pathologic fracture from metastatic bone disease, treated surgically or non-surgically with primary lung malignancy as having the poorest chance of survival. Preoperative serum albumin, hemoglobin, and ALC were not found to be significant in predicting survival, but may still be used as determinants of nutritional and clinical status of patients contemplated for surgery, which may affect clinical and surgical outcomes. Thank you.
Good day, everyone. I am Kiko Cortez from the UP Philippine General Hospital, and I'll be presenting our research on the short-term outcomes of patients with fragility hip fractures with coexisting SARS-CoV-2 infection managed in a COVID-19 referral center with an orthogeriatric team. Hip fractures in the elderly population is a significant cause of mortality, morbidity, and economic burden. Delay in management has been associated with poorer outcomes and a higher financial cost. Hence, prompt admission and a timely surgery is the gold standard in the treatment of acute fragility hip fractures. However, barriers in access to healthcare are common in low to middle income countries due to poor healthcare seeking behavior, suboptimal logistics, and problems with interfacility referrals. This was further aggravated by the COVID-19 pandemic as lockdowns were imposed and hospital resources were allocated for the treatment of patients infected with the virus. Furthermore, several authors have reported the negative effect of the COVID-19 pandemic to the overall outcomes of patients with fragility hip fractures. Kumar et al. Coined this phenomenon as a pandemic within a pandemic to highlight the burden of the coexistence of a fragility hip fracture and COVID-19 infection. In the University of the Philippines Philippine General Hospital, the first hospital designated as a COVID-19 referral center in the Philippines, the orthogeriatric multidisciplinary team and fracture liaison service continued to function as a multi-specialty service to provide care for patients with fragility hip fractures. Hence, this study aims to describe the outcomes of patients with fragility hip fractures and COVID-19 infection managed by a multidisciplinary team approach. Since March 2020, 16 patients were admitted with acute fragility hip fracture and preoperative COVID-19 infection as confirmed by an RT-PCR swab test, 10 of which were able to undergo surgery under the care of the orthogeriatric team of the hospital. Patient demographics, perioperative parameters, 30-day morbidity and mortality rates, and functional scores were documented. Mean age of the patient population is 78 years old, with majority of the patients being female. Injury to hospitalization interval was at 6.6 days, with an additional 4.6 days to get the patient to the operating room for surgery. Upon admission, 9 patients were asymptomatic, needing no oxygen supplementation, while 1 patient was mildly symptomatic, requiring oxygen supplementation through a nasal cannula. Joint replacement was done in all patients due to the unavailability of fluoroscopic imaging in the COVID OR suite. Mean operative time was 2.5 hours, with a mean blood loss of around 400 milliliters. Among the 10 patients, 3 patients developed post-operative complications. 1 surgical site infection treated conservatively, and 2 developed post-operative pneumonia. Only 1 patient died within 30 days after surgery, resulting to a 30% and 10% morbidity and mortality rates, respectively. Mean overall health status of 9 patients at 3 months post-op is 81.4 in a scale of 100, with 100 being in a perfect healthy condition. The following table shows how the patients scored themselves in terms of the 5 domains of the Eurocall questionnaire. The lower the score, the better the performance. When compared to patients with coexisting COVID-19 infection and hip fracture but did not undergo surgery, in terms of symptom presentation at the time of admission, the second group were all tagged as COVID-19 severe, and all were intubated upon admission. In terms of morbidity, all patients in the second group developed secondary complications, such as pneumonia and septic shock. All 6 patients were deemed unstable to undergo surgery. Furthermore, only 1 patient survived in the second group, giving a mortality rate of 83.3%, as compared to the first group with only a 10% mortality rate. Both differences had statistical significance. In conclusion, appropriately timed surgical intervention should be recommended in patients with coexisting COVID-19 infection and acute fragility hip fracture. Prompt admission to a well-equipped facility should be encouraged to prevent development of secondary complications. In summary, a multidisciplinary team approach should be employed to expedite timely surgical intervention prior to the development of secondary complications and clinical deterioration to achieve the best outcomes in patients with coexisting COVID-19 infection and acute fragility hip fracture. Thank you.
Good day, doctors. I am Dr. Pancho Carlo Tranquilino, and I'll be presenting our research entitled Clinical Outcomes of Ilacrest Bone Graft versus Fracture Callus in the Treatment of Nascent Malunions of the Femur and Tibia. Treatment of malunited fractures could result in significant bony defects once osteotomy or callus osteoclasis is performed. Structural defects caused by long bone fractures are often treated with bone grafts to bridge the gap in bone healing. Ilacrest is the most frequently used donor site. Different complications arise when performing autogenous bone graft harvesting. Several studies note the disadvantages of donor site complications. Donor site complications include minor complications, namely superficial hematomas, seromas, superficial infections, and painful or hypertrophic scars. Major complications include deep hematomas, deep infections, incisional hernias as pictured here, vascular injuries, iliac wing fractures, gait disturbances, nerve problems, and chronic pain. Osteogenic properties of fracture callus has been studied by Wiki et al. Their study concluded that bone callus has a potential in terms of osteoblast formation, osteoinductive factors, and osteoconductive structure. Osteogenic capability of callus was found to be superior to that of cancellous bone, leading them to indicate that bone callus can be an alternative and promising source of bone graft material. Nascent malunion of previously fractured bone is defined by poor radiographic alignment before complete fracture healing. Goto et al. Described good functional outcomes in a patient with nascent malunion of distal radius treated by corrective osteotomy with autogenous bone grafting of the defect using fracture callus. The aim of this study was to determine whether fracture callus in nascent malunion patients could be a viable alternative to iliac crest bone grafting in treating structural defects. A review of our institutional database in East Avenue Medical Center identified 214 patients who presented with acute tibial and femoral shaft fractures from January 1, 2015 to December 31, 2019. Of the 214 patients, 178 developed nascent malunion, of which all underwent open intramedullary nailing with autogenous bone grafting. Of the 178 patients, 5 who presented with pathological or bisphosphonate-related atypical fractures, and 27 with age below 18 and more than 65 years of age were excluded, which left 146 patients for analysis. We utilized reamed locked intermedullary nailing for fixation, and grafting was additionally done using ICBG or fracture callus. Decision to use either graft was based on the surgeon's preference and not on prospectively selected criteria. Early mobilization and range of motion exercises were encouraged following the procedure, although fracture type and stability of the fixation influenced whether patient was allowed full, partial, or no weight bearing. Surgical sites were inspected by second day and after operation, and the patients were sent home upon completion of IV cefuroxime regimen when no signs of deep infection or hematoma developed. For surgical site surveillance, wounds were inspected at 2 weeks after the surgery, then at 6 weeks when simultaneously checking for callus, and finally at 12 weeks in conjunction with fracture and non-union surveillance. Radiographic union was defined as the presence of visible bridging trabeculae crossing the fracture site on 3 of the 4 cortices by standard plane radiography. Data collection from the patient's medical records included interval from surgery to radiographic union and development of non-union or deep infection. We grouped our patients according to whether ICBG or fracture callus was used for grafting during the surgery and compared the mean interval to the radiographic union as well as deep infection and non-union rates. Time to union was calculated from the time of operation, and cases with no radiographic union were censored at the time of last follow-up. 144 or 99% of the 146 patients achieved radiographic union with mean interval from surgery to union of 151.97 days. Mean time estimates were 154 days and 151 days for the ICBG and callus groups respectively. Non-union rates were 2% and 1% for the ICBG and callus groups, while deep infection rates were 2% and 0% respectively. Our study did not find a significant difference in time to radiographic union, occurrence of non-union, and development of deep infection between the two groups. The use of the iliac crest as the harvesting site of autologous bone graft material remains the gold standard for restoration of bone defects and biological enhancement of impaired fracture healing. Owing to the number of complications that arise from the donor site, we wish to minimize these and look for alternative sources of bone callus. There have been studies that explored the osteogenic potential of the callus. For our conclusion in this study, we tested the null hypothesis that using the existing fracture callus from a nascent malunion shaft fracture would be a viable option to use as a grafting medium in treating structural defects and gaps to augment internal fixation. Our study showed that nascent malunion in fractures of long bones treated with reamed intramedullary nailing and augmented with iliac crest bone grafting yielded no statistical difference when compared to those augmented with morcellized fracture callus. And with that said, thank you everyone and have a great day. Here are references for your study.
Good day, I'm Aaron Paul Punzalan, and I am here to talk about our paper titled Resection Margins of Bone and Soft Tissue Extremity Sarcomas Among Musculoskeletal Tumor Specialists in the Philippines. Surgical margins are an important factor in the treatment of extremity sarcomas and have been found to be independent predictors of survival parameters. Yet, there is no uniform international standard and no consensus about reporting surgical margins, either reporting them with qualitative categories or quantifying them based on margin distances. There are different systems with conflicting definitions and recommendations. This table just shows the wide variety of classification systems for extremity sarcoma margins that have been published and employed in different institutions. With this, the following research question was formulated. Among musculoskeletal tumor surgeons in the country, how are resection margins for bone and soft tissue sarcoma managed in terms of classification and interpretation? The objectives of the study are as follows. To describe how orthopedic oncologists in the country evaluate and handle sarcoma resection margins, determine the different factors they consider in their surgical margins and choice of classification system, as well as their methods and their working environment. The study was a descriptive cross-sectional study with the participants taken from the PMTS. Data gathering was done by inviting all members of the society to answer an online questionnaire. The study had a total of 24 respondents. In terms of classification systems, the respondents were familiar with most of the systems, with the King or MSTS system being most familiar. The King and R system are also the classification systems that majority use in their practice when dealing with extremity sarcomas. The R+1 system, on the other hand, was the least used by the respondents. Majority of the respondents had ready access to both a pathologist and an FSB in the centers they practice in. For margin determination, most consider both margin distance and the quality of tissue and compartment barriers. 62.5% of the respondents also reported giving more weight to the FSB rather than clinical judgment alone for their margin descriptions in the surgical report. Majority also reported using an FSB when faced with questionable margins rather than wait for the final report. When dealing with positive intraoperative surgical margins, the respondents are split, with a third opting to proceed as planned and opt for adjuvant treatment post-op. 41.7%, on the other hand, would opt to resect additional tissue to widen their margins, while the remaining 25% would convert to a radical resection. The margin distances reported by the respondents in different scenarios are summarized in the following tables. The results show that the respondents accept a closer margin for low-grade soft tissue sarcoma as well as in high-grade sarcomas that have good response to neoadjuvant treatment. The widest margins they used were applied to high-grade sarcomas that had poor response to neoadjuvant treatment. The same trend was evident in the margin distances they used for bone sarcomas. Overall, they used wider margins for bone as compared to soft tissue sarcomas. Most respondents used the MSTS system, followed by the R system. The MSTS system is the most commonly used and reported system in the literature. The two systems were also more commonly encountered and used during their training, which would also explain their preference. There are few published data regarding the differences between the different classification systems, but one study showed that all were equally predictive of clinical outcomes, and none were clearly superior. The two commonly used systems can be used in a standardized margin system for the local setting. FSB was deemed as an important consideration for the respondents. Margin status, after all, is a key parameter affecting local recurrence rates, with positive intraoperative margins carrying a 3 times higher risk of recurrence. Based on the survey, respondents consider not only the margin distance, but also the tissue composition of the margins. It is assumed in studies that dense connective tissue provides a more robust anatomic barrier to tumor invasion. The use of wider margins when dealing with bone sarcomas could also be attributed to the need to account for intramedullary extension, especially since assessment of bone marrow margin with an FSB is technically difficult due to the fatty and bony nature of these specimens. The data shows practical working protocols involving intraoperative FSB would be feasible for most surgeons. The respondents also mentioned viable alternatives to an FSB, such as requesting for a smear. Although not an ideal alternative, published literature regarding the use of cytology as an ancillary study show that it can sample larger areas as well as accurately diagnose certain tumor types. In conclusion, this study showed that the NECing and R system were favored by most oncologists. Surgeons consider both the margin distance as well as intervening tissues when describing their margins. FSBs are also a key part of surgical management and surgical decision making. The data on margin distances, as well as further studies comparing the clinical outcomes when using different systems, would help in formulating a standardized local protocol on surgical margins. Thank you very much for your time and attention.
Greetings. I'm Joan Francine Oyperas, a resident from Chonghua Hospital, Cebu, and I'm here to present to you my research, Negative Pressure Wound Therapy for Prevention of Postoperative Wound Complications in Posterior Spinal Surgery, a 10-year retrospective study. Surgical site infection after a lumbar spine surgery during the early postoperative stage is a serious complication with significant morbidity and economic burden. Rates have been reported to be about 0.7 to 12%. Despite numerous interventions, including prophylactic antibiotic use, improvements in surgical techniques, and postoperative care, it continues to affect patients after lumbar surgery. To address this, an alternative to the usual interventions may be of interest, such as the use of negative pressure wound therapy, which enhances wound healing by reducing edema, increasing the rate of granulation tissue formation, and stimulating circulation. Lower rates of surgical site infection could lead to reduction in costs associated with length of hospital stay, diagnostic tests for microbiology, and use of antibiotics. With this, antimicrobial resistance would also be limited if infections could be avoided. So for my research question, does negative pressure wound therapy help decrease surgical site infection in postoperative spine patients? For my general objective is to compare postoperative wound complications in posterior spinal surgery of patients treated with negative pressure wound therapy versus traditional sterile dressing. It's also to determine the number of patients for each group, to determine the incidence rate of infection for each group, and to compare these rates. This is a 10-year retrospective chart review. Patient population was taken from Chonghua Hospital from May 2011 to May 2021. The inclusion criteria are those patients who underwent posterior spinal surgery, patients who were treated with negative pressure wound therapy from January 2017 to May 2021, and those treated with traditional dressing from May 2011 to December 2016, and those patients who sustained surgical site infections postoperatively. So just to show you how the negative pressure wound therapy is applied, after the closure of incision, the black polyurethane foam is placed above the postoperative site and covered with adhesive. The suction tube is attached to the machine, which provides a negative pressure. Whereas the traditional dressing would include anything from using OS, Opsite, and many more. So for my exclusion criteria, these are the patients who underwent anterior cervical spinal surgery, removal of implants, epidural steroid injections, those with a cerebrospinal fluid leak, metastatic tissue in the wounds, and allergy to any of the MPWT dressing materials. So for my data collection, evaluated both groups with regard to the following measured outcomes: the surgical site infection, wound dehiscence, and postoperative seroma. Any repeat procedure or intervention for SSI was taken into account, including the organism isolated, antibiotic used, and any revision surgery done afterwards. The variables included were patients' age, sex, BMI, and comorbidities. So this table shows the profile of the study population. There was a total of 237 patients for the traditional dressing group with a mean age in years of 47.62. There were 110 males and 127 females, whereas for the NPWT group, there were 141 patients with a mean age in years of 45.31. There were 69 males and 72 females. This shows that the incidence rate of infection in patients who underwent spine surgery. For the traditional dressing group, there were 7 patients out of 237 who sustained SSI. This group had an incidence rate of 2.95%. For the NPWT group, 4 out of 141 patients sustained surgical site infection, having an incidence rate of 2.84. The results tell us that the incidence rates are comparable for both groups. So this is the table for the demographic and medical profile of the patients, wherein the age and proportions of male and female patients, the body mass indices, and the proportion of comorbidities are comparable. So for my discussion, this table shows the 4 patients for the NPWT group who sustained SSIs. 3 patients all had multiple comorbidities, and only 1 without any comorbidities but with an increased BMI present. All patients underwent debridement and reapplication of VAC as interventions for their surgical site infection, together with the administration of culture-based antibiotics. For this next table, it shows the 7 patients from the traditional dressing group who sustained infections post-operatively. 1 patient from this group was diagnosed with osteomyelitis with subsequent debridement. Another patient underwent revision surgery 2 years after debridement. Appropriate culture-based antibiotics were also used for all patients. For my discussion, although there was no statistically significant difference between the 2 groups, 1 patient from the traditional dressing group was diagnosed with osteomyelitis and another patient underwent a revision surgery 2 years after debridement. All patients from the NPWT group achieved clean, closed postoperative sites after undergoing debridement and appropriate antibiotic use. All patients from the NPWT group had risk factors for infection such as presence of multiple comorbidities and increased BMI, whereas for the traditional dressing group, 2 patients who developed infections neither had any of the risk factors for infection. In conclusion, the study shows comparable results for both traditional dressing and NPWT groups. In order to reduce the risk of infection following posterior spinal surgery, patients should be evaluated for the risk factors with appropriate management, which also contributes to wound healing and overall recovery of the patient. These are my references. Thank you.
Good day, everyone. I'm Parvis Eduardo, a third-year orthopedic surgery resident from Veterans Memorial Medical Center, and I'm here to present an ongoing study at our institution entitled Functional Outcomes of Fragility Hip Fractures during the COVID-19 pandemic, a single-center experience. So the COVID-19 disease was declared as a pandemic by the World Health Organization in March 2020. To counteract the pandemic, the provision of essential care to infected and suspect patients were prioritized in the local healthcare setting, and urgent as well as elective orthopedic surgical procedures were delayed in order to minimize hospital entry and stay of non-infected individuals. Due to mandated measures, which included travel restrictions and social distancing, there has been a decrease in trauma cases, all the while osteoporotic and fragility hip fracture incidents remain constant. Hip fractures in the elderly are considered as orthopedic emergencies, which require early surgical stabilization, ideally within 24 hours, with the local healthcare systems focusing on providing critical care to COVID-infected and suspect patients, as well as the stringent requirements prior to managing cases in the operating room. Delays in management of fragility hip fracture cases have been inevitable, which may lead to poorer functional outcomes and higher perioperative complication rates. Multiple studies have focused on the mortality rates of fragility hip fracture patients during this pandemic. However, presently, there has been a scarcity in the literature correlating the effects of the current pandemic on the functional outcomes of fragility hip fracture patients. So the primary objective of the study is to determine the functional outcomes of included patients with fragility hip fractures who underwent operative management during the time of the COVID-19 pandemic. Our secondary objectives for the study would be to determine the pre-morbid functional status of patients to be enrolled in the study, the interval from date of injury to surgery and length of hospital stay, as well as the presence of any perioperative complication. The entire census of fragility hip fractures for 2022 at our institution will be included, more specifically all retired Philippine veteran and retired Philippine veteran dependent patients 60 years old and above who sustained a fragility hip fracture. For the exclusion criteria, civilian patients who sustained a fragility hip fracture, as well as patients who sustained hip fracture secondary to high energy trauma, and patients who wish to withdraw from the study at any point in time will be excluded. The minimum common data set as developed by the Fragility Fracture Network would be completed upon admission. Post-operative functional outcome will be determined at 1, 3, 6, and 12 months using the modified Harris Hip Score scoring system. With this study still ongoing, we have so far included 13 patients in the study, 10 of which are female and 3 are male. The age of our patients included in the study ranged from as young as 62 years old and as old as 102 years old, with a mean age of 81 years old. Majority of our patients sustained an intertrochanteric fracture followed by femoral neck fractures and subtrochanteric fractures. Here presented in this table are the dates of injury of our patients, including their respective dates of admission and dates of surgery. We also computed for the time interval between the date of injury as well as the date of surgery for our included patients. We found out that the average time from date of injury to the date of admission for our patients was 14 days, which was mostly caused by stringent requirements prior to admitting our patients, such as the need for a negative COVID RT-PCR result, as well as the hesitancy of our patients to consent to admission due to fears of contracting COVID while admitted. We also noted that the average time from date of admission to the date of surgery was 20 days, indicating significant delays in being able to bring our patients to the operating room, may it be due to a lack of operating room personnel, the difficulty in securing medical clearance, as well as the existing protocol in our institution to limit the number of surgeries that are deemed non-life-threatening. We also found out that the average time from date of injury to date of surgery was 36 days, which is far less ideal than the recommended time period of managing hip fractures in the elderly. Majority of our patients underwent partial hip arthroplasty followed by intramedullary nail fixation and total hip arthroplasty. Of note are the number of patients who underwent non-operative management due to significant medical comorbidities, which may have worsened due to the ongoing pandemic, as patients were less likely to seek consult at our institution due to fears of contracting COVID. With this ongoing study, we also note a rise in perioperative complications secondary to prolonged states of recumbency, which could be attributed to the delays in hip fracture surgeries. Majority of our patients develop hospital-acquired pneumonias due to prolonged hospital stay followed by bed sores. Our aim with the study was to determine the functional outcomes using the modified Harris-Hip score. Here on this tabulation is the summary of the results of our included patients so far. Here we note that the total score of our patients using the modified Harris-Hip score ranged from as low as 49 to as high as 85 at 1 month post-op, with the majority of our patients incurring a poor result, with only one having a good result and another patient having a fair result. The average modified Harris-Hip score of our patients was 60, indicating a poor functional outcome at 1 month post-op. This could be due to the effect of the pandemic as well, since all of our patients had delays in their consult, admission, and eventual surgeries. The devastating effects of the COVID-19 pandemic has led to less than ideal management of fragility hip fractures in our institution. Delays in seeking consult for fragility hip fractures due to fears of the ongoing pandemic, especially in the elderly population, has been rampant in our experience. We also found out that there has been a propensity of marked delays from date of injury to date of admission and eventual surgery. This is likely due to the patient avoiding immediate consult at our institution due to fears of contracting a COVID-19 infection, and the delays in surgery are secondary to the more stringent requirements prior to managing cases in the operating room, as well as the occasional lack of operating room personnel. Prolonged hospital stays have also become the norm at our institution, which is attributed to delays in clearance, the higher incidence of perioperative complications, and poorer mobility status of our patients post-operatively. A rise in perioperative complications as well as poorer functional outcomes immediately post-operatively and at 1 month post-operatively have been noted secondary to the delays in seeking care as well as the delays in surgery. Our plan is to continue documenting the functional outcomes of patients to be enrolled in this study, but the trend of poorer functional outcomes of fragility hip fractures during this time of the COVID-19 pandemic has been noticeable. Thank you.
Good day, everyone. I am Erica Nicole Chua from Makati Medical Center presenting to you my paper together with Dr. Antonio Rivera entitled Prevalence of CAM-type femoroacetabular impingement among total hip arthroplasty patients and its association with hip osteoarthritis, an 11-year cross-sectional analytical study in the Philippines, single institution study. Femoroacetabular impingement is a collection of bony morphologic abnormalities of the hip joint that result in abnormal contact during motion. CAM-type FAI relates to a non-spherical osseous prominence of the proximal femoral neck or head and neck junction. Theories on the pathomechanism of this disease includes femoral head migrates anteriorly and superiorly in the acetabulum in patients with CAM impingement. Migration is caused by the impingement and that the femoral head wanders into the impingement-related area with cartilage damage. In CAM impingement, this may be anterolateral. To determine the prevalence of CAM-type FAI among total hip arthroplasty Filipino patients, and to determine the association between FAI and hip osteoarthritis among total hip arthroplasty Filipino patients were my research objectives. A cross-sectional analytical study design was used. A minimum total of 112 subjects was advised to be enrolled with 4% margin of error at 95% confidence level and an additional 10% to account for missing data. On the other hand, in order to establish an association of femoroacetabular impingement and hip osteoarthritis, another set of sample size was computed. The computed sample size is 262, considering 80% power and 95% confidence interval. Patients who underwent total hip arthroplasty from January 2011 to April 2022 were included in the study. Those with hip dysplasia, inflammatory arthritis, osteonecrosis of the femoral head, history of hip surgery, post-traumatic arthritis were excluded from the study. Pre-op plain AP pelvis radiographs were used and alpha angle of 55 degrees and more was measured to determine the presence of a cam lesion. This figure shows that the alpha angle is determined as the angle between a line drawn from the center of the femoral head through the central axis of the femoral neck, and a line drawn from the center of the femoral head to a point laterally where the sphericity of the femoral head is lost. Using a Mohs template shown in Figure 2, concentric circles were used to determine sphericity of the femoral head. Descriptive statistics was used, the measurement of alpha angle was performed by one author, and the radiographs were reviewed again 2 months later. Here is a summary of patient profile included in the study. 63% of the study population were females, 37% were males, median age group was 68 years old, and the third pie graph shows distribution of hip laterality included in the study. Among 270 patients who underwent total hip arthroplasty, 123 patients, or 46%, were diagnosed with primary osteoarthritis. Of these, 56% had a cam lesion. Radiologic cam type FAI prevalence among those who underwent total hip arthroplasty was found in 26% of the Filipino population. Patients found to have cam lesions were also more common in male patients and those younger than 60 years old. A comprehensive historical review of FAI would show that this is not a new disease entity and that there are evidences of anatomic morphologic variants existing in the acetabulum or proximal femur in as early as the mid-19th century. The concept of FAI by Gans R. et al. Were one of the pioneers in suggesting that FAI may predispose to osteoarthritis of the hip, and addressing FAI among adolescents and active adults with groin pain may prevent degenerative osteoarthritis of the hip. Based on these different epidemiologic studies, catering to different patient populations, it shows that the cam deformity prevalence may vary depending on population ethnicity and that Western countries may have different anatomic morphologic variants compared to Asian statures. We conclude that patients with primary osteoarthritis may also be due to cam-type femoroacetabular impingement among Filipino patients, and cam-type FAI suggests an association with primary osteoarthritis among the total hip arthroplasty patients of the Filipino population. Thank you for listening. Here are my references for this study.
Good day. I am Dr. Jason A. Alamani, a fifth-year resident from Biluna Medical Center, here to discuss about the epidemiology of orthopedic fractures during COVID-19 pandemic in the military setting, a cross-sectional study. Here is the outline of my research. Coronavirus 2019 or COVID-19 is an infectious disease caused by a newly discovered SARS-CoV-2. It has become a worldwide pandemic, affecting more than 3.69 million cases in the Philippines, of which more than 60,000 lives were taken. The COVID-19 outbreak was declared on March 11, 2020 by the WHO, and the whole Philippines has been put into lockdown 4 days after. Strict measures were implemented to prevent the spread of this highly contagious disease, such as self-isolation, social distancing, home quarantine, as well as travel restrictions by land, air, or by sea. Due to COVID-19, movement of population has greatly changed, affecting the overall healthcare system. The reduction of public transportation and the termination of sports and outdoor activities contribute greatly in the decline of trauma cases, particularly MVA and sport-related injuries. During the pandemic, a number of literatures worldwide noted a decreased incidence of fracture related to MVA and outdoor activities, with majority of cases attributable to domestic and home accidents. The aim of this study is to determine the demographics of trauma patients, evaluate the fracture types, size, laterality, incidence, and mechanism of injury among patients seen on a military tertiary hospital during the pandemic period compared to the pre-pandemic period, and to know the effect of pandemic on the epidemiology of fractures in the military setting. A cross-sectional study was used to compare the data pre-pandemic to the data of the first year of pandemic. Only trauma patients with fractures of the upper or lower extremities were included. A total of 1,774 patients were reviewed with an average of 514 patients pre-pandemic and 233 patients during the pandemic. This is a graph showing the distributions of patients according to age. Despite the reduction of total number of patients, there was a similar trend of cases before and during COVID, peaking at 21 to 30 age group with a steady decline of the years after. This is a graph according to gender per year and another according to the laterality of injury. As for the rank, both pre-pandemic and pandemic data revealed majority of patients were from the rank of enlisted personnel with 53.2% and officers being affected the least. Here is the bar graph according to the fracture type. During the first year of pandemic, almost 75% were classified as closed fracture. This pattern was likewise seen during the pre-pandemic, noting a gradual decline of high-velocity trauma. Here is the human diagram showing the distribution of patients according to the injured region before and during COVID. Before COVID, data revealed that the forearm was the most commonly injured region, followed by the fractures in the leg, then hand and wrist, with the arm affected the least. Another graph comparing the two groups. During the pandemic, most patients sustained more on the leg, followed by the forearm, and with the arm affected the least. This graph showed the distribution of mechanism of injury per year. Highlighted is the time of pandemic, where nearly half of the injuries seen were secondary to MVA. Moving on to the discussion, the outbreak of COVID-19 has changed the volume and mechanism of injury for orthopedic patients being brought to the hospitals. The movement restriction brought about by the pandemic altered the presentation of patients at the ER, now secondary to domestic injuries or fall. This is according to the study of BAT and CAMA 2020, which occurs almost 4 times higher at home, based on the study of Lim et al. 2021. However, was only true to the civilian and military dependents in this study. The total number of cases seen at this tertiary military hospital significantly decreased by more than 2-folds. Contrary to the existing studies, the main mechanism of injury of patients remains secondary to MVA. Despite the lockdown and travel restrictions, the duties of the military personnel were extended as they were mobilized to serve as frontliners to aid the nation in battling the COVID virus. For this reason, military personnel were continuously at risk for road traffic accidents due to their incessant operation during the pandemic. The highest prevalence of fractures were noted at the ages of 21 to 30 years old and was observed throughout the study period. Furthermore, more than half of the patients were enlisted personnel, belonging to the above-mentioned age group, where the military career demands more of their physical capabilities as compared to later years, according to Ruscio et al. 2006. The percentage of open fractures was noted to decline during the COVID-19, similar to the data of pre-pandemic, as lower velocity of injury prevails. Furthermore, a fewer number of military personnel suffered from wartime injuries during the pandemic as opposed to the previous years, hence the direct effect of less open fractures. As for the conclusion of this study, significant reduction, or more than 56% of cases, was observed at a tertiary military hospital due to the lockdown and strict protocols. Despite the decrease in mobility and outdoor activities in the country, MVA was noted to be the predominant mechanism of injury due to the incessant operation of uniformed men as frontliners during the pandemic, where the lockdowns and travel restrictions did not stop their duty, rather extended the responsibilities to provide a helping hand against COVID. Prevalent factors during the first year of pandemic were males, aged 21 to 30, with closed fracture involving the leg, with left laterality, with the rank of enlisted personnel. Having anticipated which cases would be encountered may aid for better preparation and management, as the lockdown did not affect much of the duties of the military personnel in and out of the hospital. That's it, and thank you for listening.
Good day. I am Ana Margarita Guevara, here to present my research entitled Three-Year Retrospective Analysis of Mortality Rates in Operatively versus Non-Operatively Managed Extracapsular Hip Fractures in the Elderly. An estimated 90% of extracapsular hip fractures occur in patients aged 65 and above, and these constitute 7% of all osteoporotic fractures. These hip fractures may be treated conservatively with application of skeletal or skin traction. Operative treatment may be undertaken using a variety of implants. Early surgery has typically been considered the mainstay for treatment of hip fractures. However, the presence of comorbid illnesses in the elderly affects management. Studies regarding outcomes after conservative versus operative treatment so far have yielded conflicting results. The lack of consensus regarding the management of these fractures, which have a significant impact on the elderly, makes further investigation regarding this relevant. Therefore, the goal of this study is to determine the 3-year mortality rates and mobility status of surgically and conservatively managed extracapsular hip fractures in the elderly. The study was a single-center, retrospective cohort analysis. Patients aged 60 and above admitted in a tertiary hospital from 2016 to 2018 with a diagnosis of a low-energy extracapsular hip fracture were included. Patients with open or pathologic fractures or polytrauma were excluded. Hospital records of eligible patients were reviewed. These patients were contacted, chart data were verified, and information about the patient's status and new mobility score were gathered. Our study population consists of 86 patients, with 22% being males and 78% being females, with a mean age of 75. 89.5% of the patients were non-smokers, and 81.4% had other comorbid diseases as well. 4 patients have died, with 2 dying from cardiac problems, 1 from gallbladder disease, and 1 with unknown cause of death. All of these patients were non-operatively managed. Half of these patients were managed conservatively, while for those who were operatively managed, post-reduction surgeries were slightly more frequent at 25.6%. For this study population, the patients had an average length of hospital stay of 39 days, with a mean time to surgery from admission of 26 days. For those who were on traction, the average days in traction is 36 days. The new mobility score is a validated tool analyzing long-term mortality and functional outcomes in patients with hip fractures. A cutoff score of 5 was found to be a predictor of 1-year mortality after hip fracture. Patients with a score of 6 or below are classified as having a low functional level, while those with a score from 7 to 9 are classified as having a high functional level. In this study, the overall grand median NMS for all patients is 7. The median NMS for non-operatively managed patients is 3. Those operatively managed had higher median NMS scores, with open reduction having a median NMS of 7, while those who underwent closed reduction had a median NMS of 9. There was a significant difference between new mobility scores among those conservatively and operatively managed. In terms of those who underwent surgery, open reduction and closed reduction did not significantly differ with each other in terms of mobility score outcomes. Sex, age, comorbidity status, smoker status, and hospital length of stay did not have any association with NMS nor with mortality status. For those patients with recorded days in traction and time to surgery, we did not find any significant association as well with regards to NMS. Various studies have shown that the longer length of in-hospital stay likely translates to more complications and higher mortality. In the study of Lim et al., elderly patients with hip fractures who were managed non-surgically had a mean length of hospital stay of 17 days with a 1-year mortality of 18%. For our patients, the observed length of hospital stay is relatively longer than most of these studies at 39 days, with a 3-year mortality rate of 4.7%. Additionally, in this study, we did not find an association between length of hospital stay and mortality status. Several factors may affect the longer stay, including the institutional capacity for care, logistical limitations, and the volume of patients who are queued for surgery. Delay in surgical treatment may also influence outcomes. The studies listed in this slide cite that delays in surgery were correlated with decreased recovery and functional outcomes, increased odds for mortality, as well as increased perioperative complications. In this study, we did not find any association between days from admission to surgery and mortality status and NMS. In a Cochrane review of 5 RCTs comparing conservative versus operative treatment among hip fracture patients, there is a lack of evidence to suggest that there are major differences in outcomes between the two groups. However, the authors note that conservative treatment may only be acceptable if modern surgical facilities are unavailable, but eventual functional recovery may be slower. Another systematic review found that non-operative treatment also had higher one-year mortality rates at 48.5% compared to a matched cohort of operatively treated patients with a one-year mortality rate 19.9%. In this study, we found that there was a significant difference between the NMS of those operatively and non-operatively managed, while there was no significant difference in terms of mortality between the two groups. However, it is possible that the small number of mortalities may affect our statistical analysis, and so a larger cohort would provide better power in future studies. This study has its own limitations, including its retrospective nature, the simplicity of the Parker New Mobility Score, and its small sample size. In conclusion, with regard to the management of extracapsular hip fractures in the elderly, this research has found that while there was no significant difference between the mortality rates of those patients who underwent conservative versus operative intervention, it is still prudent to manage these patients surgically, whether by closed or open means, given the study's evidence on overall functionality of surgically managed patients as reflected by the EMS. These are my references. Thank you for listening.
Good day. My name is Dr. Charles Andrew Chu Santos from Chonghua Hospital, and I'm here to present the efficacy of epidural ropivacaine plus morphine as post-operative analgesia in major lumbar spine surgery, a randomized prospective double-blind study. Any major spine surgery is at risk for severe post-operative pain, and to control it is of great importance to prevent chronic pain syndrome and complications. Thus, strong pain stimuli itself is a risk factor for pain chronicity. Intravenous analgesics have shown to have more side effects, and epidural analgesia have been superior to intravenous route. Thus, my research question. This study will benefit both orthopedic surgeon and anesthesiologists to provide better analgesic effect on post-spine surgery patients. This will help minimize chronic pain syndrome, and this will also benefit the patient by having a better quality of life. Several studies had mentioned epidural analgesia for spine surgery. However, all used epidural catheter and each had different medications used. In a study by Gottschalk last 2004, they had 30 patients and used ropivacaine showing good pain control. Their recommendation is to use opioids. In a study by Alican et al. Of 45 patients, which is also a randomized double-blind study, they used a single-shot epidural fentanyl and bupivacaine. They administered the bolus using an epidural catheter. They reported good outcome in the epidural group based on pain score, time to ambulate, and time to discharge. A study by Kundra of 30 patients, it showed that preemptive epidural morphine for postoperative pain relief after lumbar laminectomy has good outcome in pain control. These are my objectives. This is a prospective randomized double-blind study done at Chonghua Hospital with a computed sample size of at least 8 patients per group for experimental and control. All ASA 1 and 2 patients who will undergo open lumbar spine surgery from a dorsal approach are included. Those part of the exclusion criteria will not be included. The conduct of the study was implemented after approval of the Institutional Review Board and written informed consent. A secretary who was not part of the study used a computer-generated randomization, and the list was kept blinded to the researchers. Group A was the experimental group with ropivacaine and morphine. Group B is the control group, that without morphine. And the list was placed in an envelope and would remain with the anesthesiologist. Only the anesthesiologist knows the randomization. Day prior to surgery, patients were examined with respect to preoperative pain scores and hemodynamic variables. On the day of the surgery, patients were pre-medicated, and anesthesia was induced with fentanyl and propofol. At the end of the surgical procedure prior to closure, the solutions prepared by the anesthesiologist will be handed over to the surgeon in a 5 cc syringe. The surgeon will not know which solution was prepared. The surgeon will have a direct visualization of the epidural space that was opened during the surgery, and it will inject it as a bolus using the 5 cc syringe. Closure will proceed in layers. Pain score was monitored using a standardized VAS score chart and recorded. Duration of the postoperative analgesia was taken as the primary outcome. This study used tramadol 50 mg IV when VAS score is greater than 5 as a rescue analgesic medication. All side effects are recorded. For this study, following screening and recruitment, there were a total of 18 patients. There were 10 under experimental group and 8 for control group. Demographics between the two groups is diverse and has no significant difference. All 8 patients in the control group received the rescue medication of tramadol 50 milligrams IV with a mean time of 2 hours. This has significant difference compared with the experimental group wherein only 2 among the 10 patients received the rescue analgesic. There is a significant difference with the number of rescue medications given between the groups. The control group has a mean of 1.3 number of times of rescue medications given compared to only 0.2 on the experimental group. In the control group, there was comparable decrease in VAS score on back pain at 12 hours post-op onwards. In the experimental group, however, as you can see in the table, there was a significant early decrease in VAS score at 2 hours post-op for the back and leg pain up to 24 hours post-operatively. As shown in this graph, there is a steeper decrease in VAS score from pre-op to 2 hours post-op in the experimental group, both for back and leg pain compared to the control, and it shows good control up to the 24th hour post-op. The experimental group that received ropivacaine and morphine has a better pain control post-operatively. There was also a better pain control with the experimental group with significantly decrease in VAS score, and this was maintained throughout. Leg pain shows to have a significant decrease compared to back pain, and in all patients, there was no reported adverse effects. A limitation of the study was that the data collection was done during the COVID-19 pandemic, wherein elective procedures were held to a minimum. With only 18 subjects included in this study, including more patients is a recommendation. With the results of this study, we can conclude that the epidural route using the ropivacaine and morphine as a bolus with no epidural catheter is a safe alternative. It shows good pain control and efficacy, and by this, we could limit the use of IV analgesic and its side effects, and have a better quality of post-op pain management. These are my references. Thank you.
Good day, everyone. I am Dr. Nariño, together with my co-author, Dr. Liberato Leogogo from Makati Medical Center. I am presenting to you my research on interprosthetic joint motion in bipolar partial hip arthroplasty after 1 year of follow-up. The standard of care of displaced femoral neck fractures in elderly is partial hip arthroplasty. Implants for this is either a unipolar or bipolar prosthesis. Bipolar has an advantage of longer survival attributed by motion in the inner articulation of the head, and it decreases the chances of acetabular erosion and protrusion. However, some have disputed this, showing loss of motion of the interprosthetic joint from 6 months to 1 year after surgery with the implant becoming a unipolar. Here are some literatures supporting that bipolar prosthesis eventually becomes unipolar. Though, there are also later studies supporting that bipolar prosthesis showing preservation of its interprosthetic joint motion over time. The objective of this study is to radiographically show that interprosthetic joint motion of a bipolar prosthesis persists even after 1 year of partial hip arthroplasty. This study also uses bidirectional measurements in the coronal plane. Previous studies used hip AP neutral and abduction movements, while in our study, we added hip AP adduction movement. This is a cross-sectional study which includes patients with femoral neck fracture who underwent partial hip arthroplasty using a bipolar prosthesis in a single tertiary hospital from 2019 to 2021. And these are our inclusion and exclusion criteria as stated. 38 patients were initially included. All 38 patients underwent immediate post-op hip AP neutral abduction and adduction x-rays. Patients were being followed up until 1 year. However, 24 patients were lost to follow-up and 2 patients expired. We ended up having 12 patients with 1 year post-op x-rays. Their data were collected, computed, and analyzed. Angles were measured digitally using the PACS program. For our results, there were 12 patients and 5 types of prosthesis were used. Lines, angles, and measurements were made and validated twice by the main author. Here is an example. Line 1 is drawn tangential from the inferior margin of the ischial tuberosities. Line 2 is drawn tangential to the inferior margin of the outer head. And line 3 is drawn along the center of the long axis of the femoral stem. Pelvic head angle is the angle formed between lines 1 and 2. Pelvic shaft angle is the angle formed between lines 1 and 3. A1, A2, and A3 are the pelvic head angles of the hip AP neutral, abduction, and adduction respectively. B1, B2, and B3 are the pelvic shaft angles of the hip AP neutral, abduction, and adduction respectively. In calculating the interprosthetic joint motion, we used this equation which was also done in previous studies, but added another similar equation to include the adduction values. Angles A and C are the difference of the pelvic head angle in neutral, abduction, and adduction. Angles B and D are the difference of the pelvic shaft angle in neutral, abduction, and adduction. X is the first interprosthetic joint motion from abduction, Y is the second interprosthetic joint motion from adduction, and Z is the total interprosthetic joint motion. Angle AC measures the outer head articulation, and angle BD measures the inner head articulation of the bipolar prosthesis. This is a sample of our measurement using the equation, wherein the above x-rays shows 49.1 degrees of total interprosthetic joint motion, which shows 94% of movement. This is our summary of the interprosthetic joint motions immediate and 1 year post-op. All the red numbers show more than 25%, which shows good functional outcome that may prevent acetabular protrusion and erosion. Our results showed 75% still has good interprosthetic joint motion in bipolar prosthesis even after 1 year post-op. The benefit of adding the adduction movement shows that 50% has good interprosthetic joint motion from neutral and abduction x-rays, and an additional 25% of patients were added based from neutral and adduction x-rays. 58.3% showed good interprosthetic joint motion from hip neutral and adduction x-rays, and 33% showed good interprosthetic joint motion from neutral and adduction x-rays despite poor motion on abduction x-rays. Small movements of less than 5 degrees would have been missed in 50% of patients 1 year post-op had limited views been taken with adduction excluded. Obtaining hip adduction x-rays may be important in determining the total interprosthetic joint motion in bipolar prosthesis. This is the first study measuring the interprosthetic joint motion, which includes the maximum hip adduction measurements. The reasons for the additional motion are: we can appreciate movements that can otherwise be omitted in a unidirectional movement, and adduction may disengage the stuck interprosthetic joint through the toggling effect. This study concludes that bipolar prosthesis still has mobile interprosthetic joint even after at least 1 year post-op based from hip x-rays. Additional hip adduction x-rays can give beneficial information in the computation for the total interprosthetic joint motion in bipolar prosthesis, giving a better result. And these are my references. Thank you.
Good afternoon. My name is Rui Cardoso. I'm an orthopedic resident in Centro Hospitalar Baixo Foga, and I'm here to present risk factors for development of atypical femoral fractures in patients on long-term oral bisphosphonates therapy. In the last 15 years, bisphosphonates have become the first-line therapy for osteoporosis. Although they effectively reduce the risk of osteoporotic fractures, atypical femoral fractures have emerged as a potential complication of long-term bisphosphonates treatment. This relationship is thought to be due to the inhibition of osteoclastic activity, with a coupled inhibition of osteoblasts leading to failure of repair of microfractures. The aim of this study is to evaluate clinical and metabolic characteristics in patients with atypical femoral fractures in order to determine risk factors associated. A retrospective analysis in the database of a level 3 trauma hospital registry from 2017 to 2021 was performed. Case series of 25 postmenopausal osteoporotic women under bisphosphonates therapy, aged 50 or older, and with femoral fractures due to low energy trauma were recorded. Of those, 11 met the criteria for atypical femoral fractures according to the American Society of Bone and Mineral Research, and 14 were classified as typical femoral fractures. Duration of bisphosphonates intake, metabolic factors, comorbid conditions, and concomitant therapies were compared. 11 patients with atypical femur fractures and 14 with typical femur fractures were compared. The duration of bisphosphonates intake was statistically superior in the atypical femur fracture group. Age, body mass index, type of bisphosphonates, smoking history, alcohol consumption, early menopause age, fragility fracture history, and parental hip fracture did not show statistical differences between the groups. Medical history and drugs intake did not show statistical differences between the groups. Furthermore, serum levels did not show differences between the groups. An excessive and poorly distributed load in obese patients may contribute to tensional bone failure that facilitates atypical femoral fractures. However, in our series, there was not difference in the body mass index between the groups. It was hypothesized that early lack of estrogens may cause a precocious imbalance between bone reassertion and formation, resulting in deterioration of skeletal microscopic architecture and contributing to atypical femur fractures in the presence of other metabolic alterations. In our study, although early menopause age was more prevalent in atypical femur fracture patients, statistical significance was not found between the groups. Prolonged hypocalcemia may cause poor bone formation and brittle bones that are prone to fractures. Moreover, since PTH promotes bone turnover, a decreased PTH level may exacerbate the suppressed bone remodeling in bisphosphonates-treated patients, as low vitamin D in decreasing bone mass. Our data identified normal levels of calcium and vitamin D and elevated levels of PTH. Atypical femur fracture patients received longer treatment with bisphosphonates compared with typical femur fractures, confirming a possible relationship between prolonged bisphosphonates therapy and the development of an alteration in matrix properties predisposing to damage accumulation and bone cracks propagation. Atypical femur fracture patients received longer treatment with bisphosphonates compared to typical femur fracture, confirming a possible relationship between prolonged bisphosphonates therapy and the development of an alteration. Our data indicate that longer bisphosphonates intake was statistically associated with atypical femur fractures. Early menopause age and hypothyroidism with levothyroxine intake were more prevalent in atypical femur fractures. However, statistical significance was not achieved. Thank you. Good afternoon, my name is Rui Cardoso. I'm an orthopedic resident in Centro Hospitalar Baixo Fogo, and I'm here to present risk factors for development of atypical femoral fractures in patients on long-term oral bisphosphonates therapy. In the last 15 years, bisphosphonates have become the first-line therapy for osteoporosis. Although they effectively reduce the risk of osteoporotic fractures, atypical femoral fractures have emerged as a potential complication of long-term bisphosphonates treatment. This relationship is thought to be due to the inhibition of osteoclastic activity with a coupled inhibition of osteoblasts, leading to failure of repair of microfractures. The aim of this study is to evaluate clinical and metabolic characteristics in patients with atypical femoral fractures in order to determine risk factors associated. A retrospective analysis in the database of a Level 3 trauma hospital registry from 2017 to 2021 was performed. Case series of 25 postmenopausal osteoporotic women under bisphosphonates therapy, aged 50 or older, and with femoral fractures due to low energy trauma were recorded. Of those, 11 met the criteria for atypical femur fractures according to the American Society for Bone and Mineral Research, and 14 were classified as typical femoral fractures. Duration of bisphosphonates intake, metabolic factors, comorbid conditions, and concomitant therapies were compared. 11 patients with atypical femoral fractures and 14 with typical femoral fractures were compared. The duration of bisphosphonates intake was statistically superior in the atypical femoral fracture group. Age, body mass index, type of bisphosphonates, smoking history, alcohol consumption, early menopause age, fragility fracture history, and parental hip fracture did not show statistical differences between the groups. Medical history and drugs intake did not show statistical differences between the groups. Furthermore, serum levels did not show statistical differences between the groups. An excessive and poorly distributed load in the obese patients may contribute to tensional bone failure that facilitates atypical femoral fractures. However, in our series, there was no statistical differences in the body mass index between the groups. It was hypothesized that the early lack of estrogens may cause a precocious imbalance between the bone reassertion and formation, resulting in deterioration of skeletal microscopic architecture and contributing to atypical femoral fractures in the presence of other metabolic alterations. In our study, although early menopause age was more prevalent in atypical femoral fractures, statistically significance was not found between the groups. Prolonged hypocalcemia may cause poor bone formation and brittle bones that are prone to fracture. Moreover, since PTH promotes bone turnover, a decreased PTH level may exacerbate the suppressed bone remodeling in bisphosphonates-treated patients, as low vitamin D in decreasing bone mass. Our data identified normal levels of calcium and vitamin D and elevated levels of PTH. Atypical femoral fractures patients received longer treatment with bisphosphonates compared to typical femoral fractures, confirming a possible relationship between prolonged bisphosphonates therapy and the development of an alteration in matrix properties predisposing to damage accumulation and bone cracks propagation. Our data indicate that longer bisphosphonates intake was statistically associated with atypical femoral fractures. Early menopause age and hypothyroidism with levothyroxine intake were more prevalent in atypical femoral fractures. However, statistically significance was not achieved. Good afternoon. My name is Rui Cardoso. I'm an orthopedic resident in Centro Hospitalar Baixo Foga, and I'm here to present if there is an association between varus proximal femoral geometry and atypical femoral fractures in postmenopausal women and their chronic bisphosphonates treatments. In the last 15 years, bisphosphonates have become the first-line therapy for osteoporosis. Although they effectively reduce the risk of osteoporotic fractures, atypical femoral fractures have emerged as a potential complication of long-term bisphosphonates treatment. This relationship is thought to be due to the inhibition of osteoclastic activity with a coupled inhibition of osteoblasts, leading to failure of repair of microfractures. The aim of this study is to evaluate the hypothesis of varus proximal femoral geometry as a risk factor for atypical femoral fractures in patients under prolonged bisphosphonates therapy. A retrospective analysis in the database of a level 3 trauma hospital registry from 2017 to 2021 was performed. Case series of 23 postmenopausal osteoporotic women aged 50 or older who were under bisphosphonate therapy with atypical femoral fractures were compared with women under bisphosphonate therapy without fractures on the inferior limb. The femoral neck shaft angle, hip axis length, and center edge angle were measured on the radiographs of both groups and compared. Moreover, side-to-side measurements were compared in women with unilateral pathologic involvement and asymptomatic non-previous involved contralateral lower limb. 11 patients with atypical femoral fractures and 12 with no lower limb fractures were compared. The duration of bisphosphonates intake was statistically superior in the atypical femoral fracture group. Age, body mass index, and type of bisphosphonates did not show statistically differences between the groups. Femoral neck shaft angle, hip axis length, and center edge angle were statistically different between the groups with an acute angle in the atypical femoral fractures. When comparing radiographic measurements between the ipsilateral affected side and the non-affected side, there was not found statistically differences. This study has demonstrated an association between acute neck shaft angle, proximal femoral anatomy, and the development of atypical femoral fractures after long-term bisphosphonates use. Side-to-side comparison of patients with unilateral pathologic involvement did not demonstrate any significant differences in the radiographic measurements between the pathologic side and asymptomatic contralateral lower limb. Patients on chronic bisphosphonates therapy who presented with atypical femoral fractures had more varus proximal femoral geometry than those who took bisphosphonates without sustaining a lower limb fracture. Thank you.
Intertrochanteric and peritrochanteric are generic terms for pertrochanteric fractures. Pertrochanteric fractures involve those occurring in the region extending from the extracapsular basilar deck to the region along the lesser trochanter proximal to the development of the medullary canal. The reverse obliquity fracture of the proximal part of the femur is a distinct fracture pattern that is mechanically different from most intertrochanteric fractures. In a series by Hajdukewicz et al., reverse obliquity fractures accounted for 2% of all hip fractures and 5% of all intertrochanteric and subtrochanteric fractures. Intertrochanteric hip fractures are treated using extramedullary or intramedullary devices. The proposed advantages of intramedullary devices are their superior biomechanics properties because of a shorter lever arm, reduced tensile strain on the implant, controlled shaft medialization and collapse, and less soft tissue dissection compared with the sliding hip screws. Both short and long nails are used in managing intertrochanteric fracture, but the ideal length remains a matter of debate. Good day, I am Gilbert B. Di Macali. I'm here to present my research paper entitled Long versus Short PFN in Treating Reverse Obliquity Trochanteric Fractures in Delayed Setting Among Elderly Patients, a prospective observational cohort study. The main objective of this study is to compare the outcome of elderly patients treated with long or short PFN in a delayed setting. And the following are my specific objectives. A total of 23 patients were enrolled in a study with the following inclusion and exclusion criteria. 2 patients were lost to follow-up and teleconsultation was unsuccessful. A total of 21 patients finished the study. These patients were admitted in a government hospital in NCR and a balanced skeletal traction was applied in the affected limb. Upon admission, patients were referred to different trauma services consisting of trauma residents and consultants via the weekly pre-operative conference who determined whether this patient should undergo short or long proximal femoral nailing. The intertrochanteric fracture was determined as unstable reverse obliquity by the main author with the following radiographic parameters. Fractured between the lesser and greater trochanter is starting proximal medial cortex extending to the inferior lateral cortex. Patients were followed up by the researcher until surgery and up to 1 year post-op. Type of PFN used during surgery, short or long, presence of post-operative complications, blood loss, length of surgery, length of hospital stay, time to union were recorded. Functional level at discharge 1 month, 3 months, 6 months, and 1 year after surgery were assessed by the motor subscale of functional independence measure during the follow-up visits. Out of 21 patients, 12 underwent short PFN and 9 underwent long PFN. 17 were operated by a senior resident and 4 were operated by a junior resident accompanied by a service consultant. 19 underwent closed reduction and only 2 underwent open reduction. All patients were operated more than 2 weeks from the time of admission. Based on collected data, most of the patients were females, accounting for 85.71%. The mean age of samples treated with long PFN was 73 years old, while mean age of sample treated with short PFN was 72.33 years old. Since patients from our institution are usually treated in delayed setting, comparison of number of days from admission to surgery was done. Blood loss and length of surgery were greater in long PFN, 510 ml versus 266.67 ml, and 123.22 versus 67.25 minutes respectively. Level of surgeon did not affect the length of surgery and blood loss. On the average, mean length of hospital stay of samples treated with long PFN was 6.89 days, while mean length of hospital stay of samples treated with short PFN was 8.17 days. Time to union satisfied the assumption of normality for both groups. Mean time to union of samples treated with long PFN was 7.33 weeks, while mean time to union of samples treated with short PFN was 7.5 weeks. Based on results of analysis, FIM scores did not differ between long PFN and short PFN across all time points. This implies that the type of PFN does not affect the FIM score in any subset at any time point at 5% level of significance. For my conclusion, there were no statistical difference in length of hospital stay time to union, and FIM score. No measurable differences have been observed in the complication rates of long and short PFN. Long PFN is associated with longer surgical time and more blood loss. We concluded that the use of short nail offers safe and reliable outcome comparable to long PFN with less blood loss and shorter operative time. The study is limited because of its small sample size, and the study is also limited to its follow-up of only up to 1 year. Thank you for your kind attention.
Good day. I am Michael Saturnino from Mariano Marcos Memorial Hospital and Medical Center here in Ilocos Norte, and I'm going to present our descriptive study and experience on the use of consignment method to increase joint replacement surgery. The Universal Healthcare Act of 2019 aims to ensure that all Filipinos are guaranteed equitable access to quality and affordable healthcare services protected against financial risk. Procuring joint replacement implants by a government hospital proves to be costly and may pose challenges to inventory and safekeeping of the said devices. In our hospital, prior to the consignment of these implants, we use alternative forms as the procurement method wherein the potential companies are asked for quotations of the said implant and the one with the lowest price is awarded the contract. Survey among Philippine Hip and Knee Society members on the mode of payment for their patients, and the top answer is out of pocket. How can the government healthcare facilities then respond to this problem, considering the UHC aims to avoid financial risk for our patients? Aware of the proven benefits of a consignment system for drugs and medicines, the Department of Health came up with a similar consignment system for medical devices and supplies without additional cost or investment from the hospital. This aims to help facilities have an efficient and effective process in procurement of medical devices and supplies. With this, the no balance billing of the PHIC is also addressed. Consignment is a method of assuring availability of stocks wherein a consignor places its goods at the pharmacy or CSR of the consignee for the sale, and the consignor being paid only the quantity consumed. Under the consignment method, the social service of the hospital coordinates with the various medical assistance funds for the payment of the implants and services provided to the patient. This removes the financial and procedural burden from the patient. This is our hospital in Ilocos Norte, a level 3 tertiary hospital that is set to be upgraded from 200 to 700 bed capacity. Prior to consignment of our joint replacement implants, our patients would only afford the cheapest implant available, and us, the surgeons, would also be forced to use the less optimum, less reliable implants. The implants seen on the x-rays are considered obsolete in first world countries and are already placed in their museums. However, in our country and other parts of Asia, it is still being widely used. Last August 2021, we were able to consign the following implants. This means that these implants are readily available and we are at the liberty to use whichever we deem appropriate for our patients without asking if he or she can afford one. We have also eliminated the quotations and the bidding per case, both of which prolong the waiting time. These are our results. We were able to increase our joint replacement cases in 2021 more than 50% from the average of the total cases from 2017 to 2020 combined. Let's not forget that during this time, the pandemic was still at its peak and our elective cases would be put on hold from time to time. 30 plus cases a year may seem low, but a survey from the PHKS revealed that majority of the respondents opined that doing 50 cases or more a year is already considered high volume. Of course, in the US, it takes more than that. Our dropout rate is 3%, meaning 97% were able to undergo the surgery. The 3% either didn't consent or has a serious medical comorbidities. Compared that before we had the consignment, 47% didn't proceed with the surgery primarily because of financial reasons. And this was reflected in the survey. 95.2% of the respondents answered financial as the main reason why their patients refused surgery. We also noticed a decrease in duration of the time from initial consult to surgery. On the average, patient is operated on the 6th day from the initial consult. We hope that once the pandemic is over, we would be able to achieve the ideal 24 to 48 hours initial consult to surgery for our hip fracture patients. Prior to consignment, it would take at least 2 weeks from initial consult to surgery. We have an average of 3 days from surgery to discharge. We are more confident to discharge our patients earlier, knowing that the system we are using are more reliable than the old implants we used before. Average duration of stay for our patients was 8 days. Having a lower duration of hospital stay means more savings for the hospital. We hope to improve on this since the trend now is outpatient surgery for joint replacement procedures. Although the main reason why our patients stay longer is because of the COVID RT-PCR requirements and the limited OR slots our department have. These are the variety of cases where joint replacement implants were used. Number 1 leading diagnosis is still intertrochanteric fracture. Bipolar cemented is the most commonly used implant, followed by total hip replacement cementless ceramic and ceramic. So in conclusion, consignment method contributed significantly to the increase of our joint replacement implant cases. And the consignment method adheres to the provisions of the Universal Healthcare Act. It covers all patients, provides quality orthopedic care, and protects the patients from financial risks. The challenge now is to make our colleagues aware of this system since in the survey I have been mentioning, 50% of the respondents who work in the government hospitals are not yet aware of this procurement method. Thank you.